Hello, hello. Hello, hello. Hello, 1, 2, 3, 4, mic testing, check. Hello, 1, 2, 3, 4. Hello, hello. Hello.
Ha. Getting the proper sound.
Hello.
आपला व्हिडिओ सेव्ह करून घेतो.
Getting the proper sound. Sayukta, you there? Am I audible? Sayukta?
Hello. 17.
Yes. Good afternoon, Poonam ma'am and Manju ma'am. Maushmi ma'am.
Good afternoon.
Just starting in a while.
Sure.
On time.
आवाज नहीं आ रहा है किसी का.
Can you hear us? Hello?
Yes, ma'am. Hello.
Okay. You are audible, no?
Yes, ma'am, you're audible very much.
Hello. Hello, mic testing, check. Mute kar.
आवाज ही नहीं आ रही है.
सब स्पीकर हटा दो. इससे तो आवाज.
Hello, mic testing, check.
Are we audible?
Madam, 1 second. Hello, hello. नहीं उससे ऐसे नॉर्मल.
Yes.
Hello.
Yes, we can hear you.
Are we audible?
Yes.
Audible?
Yes.
A very good afternoon, all. I'm Dr. Sharvari Lothe.
And I'm Dr. Sayukta Davle.
It gives us an immense pleasure to extend you a warm welcome on behalf of NOGS and Department of Obstetrics and Gynecology, NKP SIMS and Lata Mangeshkar Hospital, Nagpur, on the third day of this academic feast, NOGS PGCON 2022. Today is a birth celebration of a great leader, a worshipper of education and democracy, Janata Raja Chhatrapati Shivaji Maharaj. So I wish you all a happy Shiv Jayanti. Yesterday we had a great session which will definitely help our PG students for their exams as well as in their clinical practice. So continuing the same, let's start with today's session.
So schedule for today is, first we are going to have our case presentation. After that, table viva. After that, we are again having case presentation. And lastly, we will have skill station video presentations.
Let's go through the rules of the case presentation. For case presentation, total duration is 40 minutes, 10 minutes for case presentation by the student, 25 minutes by case viva, and last 5 minutes to summarize the case by the examiners. A sincere request to all to use good network connection to avoid technical hindrance.
As we all know that PH is the most leading cause for poor perinatal and maternal outcome. Hence, it is very certain to know about it and discuss it for our clinical practice as well as from exam point of view. Our next case presentation is on hypertensive disorder in pregnancy by Dr. Priya Sontakke from NKP SIMS LMH Nagpur. Our faculty judges are Dr. Poonam Verma ma'am, Dr. Manju Puri ma'am, Dr. Maushmi Tadas ma'am.
Dr. Poonam Verma ma'am, she is a professor and HOD of in Department of OBGY, MGI MS Sevagram Vardha. She has received advanced training in SHRH from Uppsala University, Sweden. She has been also trained in emergency obstetrics care from CMC Vellore. She has received advanced training in obstetrics HDU and ICU management. She is also a member of PPH working group, FIGO. Dr. Manju Puri ma'am, who doesn't know her? She is a director and professor of obstetrics and gynecology, Lady Hardinge Medical College, New Delhi. She is a member of National Academy of Medical Sciences, she is a member of Fellow Indian College of Obstetrician and Gynecologist. She has received many awards. She has received gold medal for the best paper at the 6th World Congress of Reproductive and Child Health. She has n number of publications to her credit. Also, she is presently a chairperson of Quality Improvement Committee of AOG. She has edited many books, amongst which some are Anemia in Pregnancy, Management of High-Risk Pregnancy, a Practical Approach, and Clinical Methods in Obstetrics and Gynecology. Her field of interest are high-risk obstetrics, infertility, and reproductive endocrinology. Dr. Maushmi Tadas ma'am, she is an associate professor in GMCH Nagpur with vast teaching experience of more than 8 years. She is a fellow of Indian College of Obstetrics and Gynecology and life member of IMS. She is a PG guide and examiner for MUHS. Her areas of special interest are high-risk pregnancy, infertility, gynec endoscopy, vaginal surgeries. She has received special prize for paper presentation in Gynecon. She has been faculty in many conferences and delivered talks. She has n number of publications in national and international journals. We welcome you all, ma'am. Priya, over to you. Start presenting the case.
Yeah, please unmute yourself and share your screen.
Oh, a very good morning to all. So looking forward to a presentation by Dr. Priya. Am I audible?
Yes, ma'am. So Yukta, please stop sharing from your side. Then Priya can share.
Priya, so you have 10 minutes to present your case. And then we'll move on to the discussion.
Stop. Yeah.
Hello, good morning all.
Hello, Maushmi
Good
ma'am.
afternoon all. Hello.
Full regards and welcome from NOGS and NKP SIMS. Manju ma'am, Maushmi ma'am, Poonam ma'am.
Thank you so much.
Thank you.
Am I visible, ma'am?
Yes.
Yes, please
go ahead. Yeah.
take it on slideshow. It would be better. Yeah.
Good afternoon, everyone. My name is Dr. Priya Sontakke from NKP Nagpur. I'm starting my case presentation. 20-year-old patient, he is a sex advisor who was married since 10 months. Hindu by religion, residing in house number 40.
Priya, your slides are not moving. Priya, your slides are not moving.
Priya,
And
please
put it on
share
a
your
slide.
screen.
You can reshare it.
Please make it a slideshow.
Priya, stop sharing and again reshare. I think there was a network issue for which it did not move. Yeah.
Is it visible now?
Yes, please go ahead. Yeah.
So I start again. A 20-year-old patient, Mrs. XYZ, who was married since 10 months, Hindu by religion, residing at house number 42, ward number 8, Hingla Road, Nagpur, belonging to lower socioeconomic status by modified Kupuswamy classification and was housewife by occupation, came to our OPD. She was primary gravida, came with history of 8.5 months of amenorrhea with calculated gestational age of 30 plus 2 days with outside BB of 160 by 100 millimeters of edge. My patient was apparently all right 10 days back when she noticed swelling over both feet, for which she went to private practitioner's OPD 2 days back with complaint of swelling over bilateral feet. No history of relief of bone rest. There was no history of pain in abdomen, bleeding or leaking per vaginum. There was no history of excessive weight gain. There was no history of fever with rash, cough, cold and breathlessness. There was no history of headache, nausea, vomiting or blurring of vision. There was no history of oliguria, upper epigastric pain, or there was no history of increased BP reading before birth. It was spontaneous conception. Pregnancy was confirmed by urine pregnancy test done at Anganwadi after 15 days of missed menses. Patient was registered at outside private hospital at 6 weeks. All routine investigations were done and dating scan was done at 6 weeks, which was suggestive of single live intrauterine pregnancy and corresponding to dates. Her NT-NB scan was done. Scan was not done. She was started on tablet folic acid on first visit. There was no history of drug intake or radiation exposure. There was no history of excessive vomiting or bleeding in first trimester. In the second trimester, quickening felt at 5th month of pregnancy. She received 2 doses of injection tetanus. She consumed iron and calcium supplementation from 20th week. Anomaly scan was done at 18th week, which was normal. There was no history of nausea, vomiting, and epigastric pain. There was no history of swelling over feet or puffiness or raised BP readings in this trimester. She had total 3 visits in trimester, 18th week, 22nd week, and 26th week at outside hospital. And then she registered herself at our hospital at 27th week. In third trimester, she was perceiving fetal movements well. She was consuming iron and folic acid supplementation. There was no history of pain in abdomen, bleeding, or leaking PV. There was no history of nausea, vomiting, headache, epigastric pain, oliguria, blurring of vision. There was no history of swelling of feet or raised BP records before birth. There was no history of decreased fetal movements. USG was done at 34 weeks, suggestive of single live intrauterine pregnancy corresponding to 31 weeks of parameters, with posterior placenta adequate liquor with fetal weight of 2.021 kilograms. Her obstetric history was she was married since 10 months, non-consanguineous marriage, primary gravida with spontaneous conception. Menstrual history, age at menarche was 14 years, previous menstrual cycles of 3 to 4 days average flow, coming every 28 to 30 days, which was not associated with dysmenorrhea. Her LMP was 15th of June 2021. Her EDD is 22 March 2022. Her calculated gestation is 34 plus 2 weeks. Past history, there was no history of bronchial TB, thyroid disorder. There was no history of blood disorders. There was no history of chronic renal disorders or any bleeding disorders. No history of major surgery, blood transfusion, or drug allergies. Family history, there was no history of hypertension, asthma, TB, thyroid disorder in family. There was no history of hypertensive disorder in pregnancy to mother and sisters during their pregnancy. There was no sickle cell anemia or thalassemia in family. There was no history of blood transfusion in family also. Personal history, she was taking mixed diet with adequate sleep, bowel and bladder habits normal, appetite normal. There was no addiction of drug or drug allergies. Dietary history was taken by 24-hour recall method. Total calorie requirement of 2400 kilocalories. She consumed 1,850 kilocalories with deficit of 550 kilocalories. Total protein required was 60 grams, but she was consuming 28 grams with deficit of 32 grams. On examination, she was conscious and oriented to time, place, and person. She was thin built with weight of 49 kgs and height of 154 centimeter. Her BMI was 20.7 kilogram per meter square at present. Her pre-pregnancy BMI was 17.7 kilogram per meter square. Total weight gain in pregnancy was 7 kgs. Temperature febrile with pulse of 82 per minute, regular good volume. BP of 160 by 100 millimeters of Hg taken in right arm in sitting position. Her respiratory rate was 20 per minute regular. SpO2 was 98% on room air. Urine albumin was done, which was 3+. There was no pallor, cyanosis, icterus, or clubbing. Bilateral pedal edema was present, pitting type with grade 2. Thyroid was not enlarged. Deep tendon reflexes were normal. Bilateral pupils reactive to light. So cardiovascular examination was done, which was normal. S1, S2 were heard with no murmur. Respiratory examination, air entry was equal on both sides with no adventitious sound source. CNS, she was conscious and oriented. On per abdomen examination, on inspection, abdomen was longitudinally ovoid, umbilicus everted, linea nigra and stria gravidarum seen. There was no visible scar marks over abdomen, though no dilated veins. Hernial orifices normal. Fetal movements could be seen. On palpation, height of uterus was 30 weeks. On first Leopold, broad, soft, irregular mass felt suggestive of breech. On second Leopold's, on the maternal right side, smooth curve resistance felt, which suggestive of back. On maternal left, maternal left side was comparatively empty with knob-like structure suggestive of limbs. On third Leopold, smooth, hard globular palatable structure felt suggestive of head. On auscultation, fetal heart sounds were present with the rate of 130 per minute on right spinoumbilical line. Liker was clinically adequate. Estimated fetal weight was 1.9 to 2.1 kg, well relaxed with no uterine tenderness. So my clinical diagnosis is primary gravida with 34 plus 2 weeks of gestation with severe preeclampsia with IUGM. I have investigation. Should I show you the investigations?
Just a second. Can we just, highlight a few things on the history? So very well presented. The first and the foremost is that, Priya,
yes,
when we start with the complaints, so in this patient, what was the complaint which you had put in? Just go to the first slide, please.
Yes, ma'am.
Quick movement to the first slide. Yeah. So, yes. So you've written that she was a primary gravida, came with history of 8.5 months amenorrhea with calculated gestation age of 32 plus 2 days with outside BP reading of this. So I think it is better to put it as that she is a primary gravida at 8.5 months of amenorrhea and has been referred.
She was referred, ma'am.
Yeah, referred with high BP records.
Yes, ma'am.
For further management. No, so it makes it very clear.
Okay.
So
yes, she was referred actually.
Yeah, it is the complaint with which the patient is coming. That should be very, very crisp and clear. Okay.
Yes.
So this is how it should be. The second thing which I wanted to know was that come to the diagnosis, the last part.
Can I highlight something on the history? I would also like to ask some questions.
Yes, Dr.
Yes, she said that the dating scan was done at 6 weeks of pregnancy.
Yes, ma'am.
So ideally, at what the gestation you do the dating scan? Is it done at 6 weeks or? Can you answer this question? At what gestation ideally you should perform a dating scan?
No, actually, she went to Anganwadi at that time, so scan was done. But normally it should be done.
But is it a dating scan if you do at a 6 weeks of gestation? Is it a dating scan? You call it as a dating scan?
No, ma'am. It was first scan was done at that time. Dating scan should be done at 8 to 12 weeks.
Yes. So you have to correct that it wasn't a dating scan. It was just a viability scan, you can say. And ideally, at what gestation should you do the dating scan?
8 to 12 weeks, ma'am.
Yes. And what parameters should you see to look in for that? What is the ideal parameter to see?
Crown rump length
should
be seen.
Yes. Okay. And one more thing, I would like to ask a question here, which you would be asked in your exams also. You said that the urine albumin was 3+.
3+.
Yes. Then you should add a line that by which method it was done. Like
dipstick.
Yes, ma'am. Yes. So it was done by dipstick method.
Yes.
Okay. And you should also know that if it is 1+, like urine 1+, 2+, 3+, how much urinary protein it comes out to be. So if it is a 3+, then what should be the urinary proteins?
3 grams per deciliter.
Yes. So that is what. So it is a significant proteinuria.
Significant proteinuria. Above 1+ is significant.
Yeah. So one more question I would like to ask from your history, like from your history and clinical examination. What are the risk factors for this pre-eclampsia and this patient?
Firstly, she was primigravida with
Yes.
20 years of age, that is
Yes.
early age.
Yes.
Second, lower socioeconomic status, which is more predisposing to
Lower socioeconomic status, it actually doesn't come, it doesn't count, it is not counted as a high risk factor for preeclampsia. Anything else? There were no factors in your patient like historical. In history, any factors were there? In your patient, it was not there. But what specifically you should ask if a patient comes in a first trimester or in pre-pregnancy, you should know all the risk factors.
family history of, if she is known
Yes,
case of any
family history of what? Family history of what?
preeclampsia in mother, sister,
Yes.
or if twin sisters, because
Yes,
they
yes.
increases the risk.
Yes.
If she is any known case of diabetes or
Yes.
any
Diabetes,
autoimmune
yeah.
diseases like
Pre-existing
SLE,
diabetes or chronic hypertension, then any other disorders?
SLE, renal diseases,
Renal disorders, right? And one more?
insulin resistance, DM. That is.
Of course, that is there.
Eight.
Then thrombophilias.
Yes.
It is less common in our area, but you should know. I'll ask. Yes. Any other risk factor you should calculate or see?
Gestation.
Yeah, age you have said. Then any other thing is important? Like weight, according to if it's a weight, is there an importance of weight?
Yes, ma'am. BMI.
BMI, right? BMI is important. So BMI more than what is significant? What the BMI? What?
More than 30 BMI.
More than 30 BMI is a high risk factor for preeclampsia. Any other thing, like if you are taking a general examination, which point is important in that? If you are looking, you are seeing if she comes in a first trimester or an early second trimester. If you're checking her blood pressure, I'm giving you a hint. What should be calculated from her blood pressure?
Mean arterial pressure should be calculated. So we know the basic normal baseline mean arterial pressure.
Mean
if it increases by
more than what is significant?
More than 105 is significant. And in later pregnancy, if it increases by 20 mm of Hg, then it is significant increase.
So these are the various historical, if there's any other endocrinal disorder like hypothyroidism also is important. In pregnancy, if it is conceived with any
metformin
or ART is also a significant. And if the patient is having anemia, then short marriage
interconceptional period less than
conception. Short means cohabitation, right? Short exposure.
Less sperm exposure.
So these are the risk factors you should know from the history. If she is coming from for any marriage like pre-conception counseling or in the first trimester, so that you can start with her some preventive measures.
Aspirin can be started. There were 2 trials, aspirin trials. They said that low dose aspirin should be given. They recommend 150 mg of aspirin for prevention of mainly preterm preeclampsia. But ACOG says 81 mg of aspirin can be given starting from 12 weeks of gestation till delivery.
And what does Foxy recommend? How many milligrams?
Low dose aspirin only.
Foxy recommends 75 milligrams.
75 mg daily.
For Indian women, that's doses
adequate.
So you can continue. What were the investigations? You can show us.
Can I just have a little discussion on the clinical diagnosis, Priya?
Yes, ma'am. Yes, ma'am.
Priya, do you think your diagnosis is complete? The diagnosis should include everything which requires management in your patient or which will affect the management. So please complete the diagnosis.
20-year-old female primigravida with 34 plus 2 weeks of gestation with severe preeclampsia with IUGR.
So would you like to mention the presentation?
Cephalic presentation.
Yeah. And would you like to tell us whether the baby is live or it is IUD?
Yes, with live pregnancy cephalic presentation.
Yes. So I think it is important to add that because that is going to ultimately affect.
And delivery can be.
And you have said IUGR. So have we confirmed the diagnosis of IUGR or with suspected FGR, you will call it?
Clinical diagnosis, ma'am. Per abdominally, she was at 34 weeks of gestation. She was 30 weeks, uterine height was 30 weeks per abdominally. So
yes. So what could be the other causes for a disparity between the fundal height and the period of gestation?
There can be wrong dates,
Yeah.
first of all, but dates, her dates was confirmed. There can be constitutional small baby.
It could be IUD. Yeah.
It can be IUD of 30 weeks, but
IUD also.
FHS would present.
So we are, leading to a situation wherein it is much better to say with suspected IUGR.
Suspected IUGR.
So that means you cannot make a final diagnosis of IUGR based only on your clinical examination.
Clinical diagnosis.
Right? So you will say it is suspected or
Clinical.
to be evaluated for FGR. Okay. So
Yes.
that is what your diagnosis would be.
Yes,
She did not have any anemia? No, there was no pallor?
No. Pallor, no.
All right. All right. Now you can first tell us what investigations would you like to do in this patient? Or before that, there was one thing which you mentioned on the, on ultrasound. You gave us the details of ultrasound. So that should not come as a part of your history and examination.
Okay. Yes.
Yeah. So it should come as a part of your investigations. Right?
Yes,
okay. So what are the findings which will help you suspect FGR on clinical examination? One is the disparity between the fundal height and the period of gestation. Okay.
Symphysiofundal height.
Did you measure the symphysiofundal height in your patient?
Yes, ma'am. It was 32 centimeter. So.
No, did you mention it in your examination?
I didn't mention it, but the symphysiofundal height was taken at the patient.
No, but if the period of gestation is 34 weeks and the symphysiofundal is 32 weeks, would you say it is FGR?
No.
How much should be the difference for you to suspect FGR? It is 3 centimeter. Okay. So 3 weeks or 3 centimeters is what is the difference when we would suspect. Okay, that's fine. So with a fundal height of 30 weeks, if you say the fundal symphysiofundal height was 32 centimeter, I would agree. But one needs to be very careful when you give a per abdomen height of 30 weeks and you calculate a symphysiofundal height of 32 centimeters, right?
Yes, ma'am.
Okay, so this is one thing which you have to be careful about.
Yes,
all right. So other than the fundal height, anything else which can help you suspect FGR on clinical examination? What about the Leica?
Leica was clinically adequate. I have mentioned.
No, but in case the Leica is less, then even if the fundal height is corresponding, you can still think of FGR. Okay.
Yes.
So these are 2 parameters which can tell you whether your patient is likely to have FGR. So Leica is very important in preeclampsia. Okay. Over to you, Dr. Mosmi. You can go ahead. Yeah.
Yes. Please let us know what were her investigations and what Madam has already asked you. What investigations would you like to do?
I will do her ANC. She was having all ANC profile like blood group and CBC and all investigation. When I repeated her investigation on admission, her HB was 12.9 milligram per deciliter with platelet count of 1,95,000 per microliter. Her peripheral smear examination shows microcytic hypochromic RBCs with anisocytosis. Total LFT was done. Total bilirubin of 0.5 milligram per deciliter. SGOT was 25, SGPT was 14 international unit per liter, uric acid was 5.6 milligram per deciliter, urea was 14 milligram per deciliter. Her creatinine level was 0.7 milligram per deciliter, sodium was 137, potassium was 4 milligram per deciliter, LDH was 110 unit per liter. Her bleeding time was 1 minute 13 seconds and clotting time was 5 minutes 10 seconds. Her INR was 0.7. Fundus examination was done.
Can I just interrupt, Beta?
Yes, ma'am.
Do you measure the sodium and potassium as milligram per deciliter?
Milliequivalent per.
You can't make these kind of mistakes, right? You have to be careful about it. Okay.
Yes,
all right. Go ahead.
Fundus examination was done, which was within normal limit. That's all.
So, any abnormality in the investigations?
Not as such. But uric acid was slightly raised. 2 to 4 is normal level. Her uric acid was 5.6, which is
with a hemoglobin of 12.9, why would she have microcytes, anacytosis, hypochromic RBCs? Does it kind of ring a bell in your brain?
It is due to
I was also thinking that only. How come it is hypochromic microcytic when the hemoglobin is 12.9? But still, you can have an answer for this if you think.
The 12.9 HB can be due to hemoconcentration.
Yes.
Due to preeclamptic state of patient.
So it looks as if she's got hemoconcentration. So one would like to verify and not just neglect it, right?
Yes.
So it is something which is, I asked you what is abnormal in the findings, investigation. You should be able to point out this part also. There's a mismatch between the peripheral smear and HB. And the
Any other investigations were done, or would you like to do? This is all?
US Doppler should be done to see.
So the USG, you can show us
you can show
findings
the
again,
here.
because a lot of things were missing there. Show us the ultrasound report.
We didn't do ultrasound after admission, ma'am. Actually, we terminated her.
No, but we saw the ultrasound report.
Achha, on this. No? Yes.
Yeah.
34 weeks suggestive of single life pregnancy corresponding to 31 weeks parameters with posterior placenta and adequate.
So if you do an
life
ultrasound,
2.02.
if you do an ultrasound, what all would you look up in your patient?
Firstly, presentation, placenta, parameters, abdominal.
What in placenta? What in placenta?
Position, grades of calcification.
Grading is not important these days. So placental localization.
Localization.
Okay.
Yes. Liker, parameters like abdominal circumference, any FL, femoral length, and baby weight. And I would like to do.
So you can always say, use the right term, biometry. You will do fetal biometry.
Fetal biometry.
Which includes, okay, you can always express it like that. Okay.
Yes.
Like it will include biparietal diameter, FL, abdominal circumference, right? Okay. What else?
I would like to do Doppler, bilateral ambulatory and ambulatory Doppler.
So when you are looking at the fetus, would you not like to look up, rule out any gross congenital malformation also?
Yes, ma'am.
So you must complete the list of things which you are going to look at in the baby, no?
On ultrasound, what all things you are going to see? You just complete the list. Madam has asked you, please tell us all the things. What are you going to see?
Starting from presentation, then placenta, localization, liker.
What are you have mentioned, that's okay, but
Achha.
in addition to that, you said something about liker. So what, only liker? So in liker, what would you see? You have to talk specifically.
Deepest vertical pocket.
Deepest vertical pocket, okay. And apart from these, what will you see? Would you like to do a biophysical profile?
Yes, modified biophysical profile, fetal tone, breathing movement.
That is what is modified biophysical profile?
It includes NST and AFI.
I'll call you later.
Okay. So remember that when you are talking about ultrasound, you must always start systematically, the number of fetuses, the fetal biometry, whether cardiac activity is there or not. So,
yes,
that part should be absolutely any gross congenital malformation. So always go systematically so that you do not miss out anything, right? So it's always better to follow a pattern. Okay. Now,
and here also I would like to say that instead of measuring the average gestational age, you should each value like how much was the head circumference in centimeters corresponding to, so that you can correlate how many weeks the lag, how much the difference is there. If there are ratios are mentioned, then you should mention the ratios, right? Because that is important to know the severity of the fetal growth restriction.
Yes.
Right? And in Doppler, which Dopplers would you like to do?
umbilical artery Doppler, middle cerebral artery Doppler, and
What would you see in that?
I'll see the cerebroplacental ratio.
Mm-hmm. It was not done in your patient?
Huh, ma'am?
Doppler was not done in your patient?
No, ma'am. Only plain USG was done.
Why Doppler was not done? Is it not important?
She came with this report from outside only.
So it was not done in Doppler was not done in your.
Not done in this.
But is it necessary? Is it necessary?
It was necessary to see the IUGR and baby fetal condition.
What do you see in the Doppler? Means what specific you would like see in the what you come to know from the Doppler?
In umbilical artery, we should see PI of umbilical artery and middle cerebral artery. And
what does each of these signify? So why do you want to look at middle umbilical artery, and why do you want to look at middle cerebral artery?
You see fetal hypoxia is there. If middle cerebral artery PI is if the ratio of middle cerebral artery upon umbilical artery is less than 1, then it shows the brain sparing effect.
Sorry, could you just come again?
If the ratio...
No, let's not mix it up. First of all, do we start calculating the ratio in the beginning, or first we look at absolute values of the umbilical artery flow and middle cerebral artery? We will switch over to middle cerebral artery only generally after the, the umbilical artery flows are looked up, no?
First we see the umbilical artery flow, diastolic flow. And if that is impaired, then we go to middle cerebral artery because it is last to go, because the perfusion is such that the vital organs should get most of the blood supply. And
all right, then all right. So what happens to the flow in middle in umbilical artery?
There is forward flow.
No, in FGR, what is the effect of FGR? What is the findings likely to be in a case of FGR in umbilical artery blood flow?
There can be absent diastolic flow, then reverse diastolic, decreased diastolic flow, and finally reverse diastolic flow.
Okay, so basically there is a decrease in flow, all right?
Yes.
So what happens to your peripheral resistance, PI?
PI increases in such conditions.
So initially you will have a rise in PI, then it could be absent end diastolic, and the last would be reversed end diastolic. Okay. Now, is it possible in your patient who's got FGR that the umbilical artery flow may be normal, but the middle cerebral artery flow may be abnormal? Can this happen?
Yes, it can happen.
So does it happen in the early part of gestation, or does it happen later in the gestational age? You were referring to the cerebral placental ratio, no?
Yes, yes.
Middle cerebral artery flow divided by umbilical artery flow. So I'm asking that this is more relevant in the early half of pregnancy or late half of pregnancy? Or
the late half of pregnancy.
The later half of pregnancy. Yeah. So that is what is important. So we will look at this aspect in the later half of pregnancy, even if your umbilical artery flow may be present. Okay. So you would still look at it because it can give you a clue that there could be FGR. Okay. Do you understand that?
Yes, ma'am.
All right. Okay. Fine. Dr. Mosme, please go ahead.
So what did you do? How did you manage this patient?
She was labeled as severe preeclampsia. So
just a second. Why did you label it as severe preeclampsia?
Systolic BP on admission was 160 by 100 mmHg.
By 100.
By 160 systolic with diastolic of 100 mmHg, and her outside reading was also 160 by 100 mmHg. So 2 readings were there. So it is severe preeclampsia, and her gestational age was more than 34 weeks.
Any other factor was present to label her as severe preeclampsia?
No, but one factor is urinary bleeding was +3, but it is not diagnostic.
No, there is one more factor present in your patient to label her as severe preeclampsia. There's one which just now you had discussed. Did your patient have, your patient had a fetal growth restriction? So is it a part of severe preeclampsia?
This is not, FGR is not considered as a diagnostic.
What are the factors you have considered? FGR is not considered if a patient is having FGR of a preeclampsia. Is it not considered as severe preeclampsia?
No.
No?
No.
Then what are the factors on which you label the patient as having severe preeclampsia?
VP reading of 160 of diastolic with 110 of 160 of systolic and 110 of diastolic, with proteinuria of more than 2+, with other organic organ damage, like her liver function test showing SGOT and SGPT levels of twice than normal, her creatinine level of more than 1.1, platelet count of less than 1 lakh per deciliter. If any other signs of organ damage, like retinal changes, signs of cerebral edema, signs of pulmonary edema, blurring of vision, that is any presence of any premonitory sign symptom. When any of this factor is present, we can call it as a severe preeclampsia.
Was your patient on any antihypertensive?
No, ma'am. One outside reading was 160, 100. She was directly referred to us.
Could we have waited in this patient?
No. Diagnosis should be made in minutes, and the antihypertensive should be given.
No, I agree. But your patient, could we have put her on antihypertensive and maybe, it was one reading outside and one reading at your end. So
Yes.
what does the definition say when you say severe hypertension? So what does it say? Should a single reading at your place is okay, or you should have taken one more reading and monitored her BP for a while and then labeled her as severe hypertension?
Second reading should be taken in minutes only to diagnose it earlier, and antihypertensive should be given.
Was your patient having any warning signs and symptoms?
No. Edema was there, if she was not having any symptoms.
So, there could be a difference in opinion, but I feel that in this patient, we should have, waited for some more time, started her on antihypertensives. Okay. 160 is just borderline, and her diastolic BP was also
100.
It was 100. So she qualified for she is preeclampsia, but not categorically being, categorized as severe preeclampsia, because if you look at the ACOG guidelines, they say that if you have 160, 110, 4 hours apart, you are right that if you have more than 160, 110, you should take it as early as possible. There's, some people take it immediately, some people take it after half an hour or 15 minutes. Others would take it at once, after 4 hours. So in this kind of a patient where you do not have any other symptom or sign and all her biochemical parameters are normal, it seems, relevant that in this kind of a patient, we can start her on antihypertensive and, see how she goes on and then take a call.
Yes. Ma'am, we are left with only 5 minutes.
Yeah. So,
sorry to interrupt you,
do you want to ask something?
So how will you go about with this patient? Let us know.
She is gestationally across 34 weeks, 34 plus 2 weeks. So termination should be done.
Before termination, would you like to give us something?
Magnesium sulfate was given to her. Magnesium should be given to every severe preeclamptic patient. So it was given to her.
For what you should give her? Let us know.
For neuroprotection and seizure prophylaxis, that is seizure prophylaxis. Termination.
You need to give neuroprotection at 34 weeks. Is it required?
No, seizure prophylaxis. For seizure prophylaxis.
So you should be very clear as to why do you want to give it.
Yes.
Okay. How would you?
Can I ask a question, please?
Yes, Dr. Poonam, please come ahead.
Yeah. Ma'am, I have one question to her, that we do these investigations in non-severe and severe. How frequently do you do these investigations and how do you interpret them?
In non-severe preeclampsia, twice weekly investigation should be done. Investigations include her platelet count, LFTs, mainly serum aminases, transaminases, and creatinine.
So could you please tell us that which are the investigation which you need to do alternate days? Which are the investigations you need to do twice a week? And what is the significance? Why are we repeating these investigations?
Our daily INR, transaminases, and should be done daily if we are conserving her. Creatinine, INR, and transaminases should be done daily. And
so if you look into severe preeclampsia, we have two groups. One group is preterm and another is term. The one which is term, obviously you would like to deliver her. But when she is preterm, in those cases, you have to repeat. And there are few things which you have to know. One is that if the platelet count is going down significantly, your liver function test is specifically, ALT and ST increasing. And then, of course, your blood coagulation profile is changing. So these are the indication of immediate termination of pregnancy.
Yes.
It is possible that she is going into HELP syndrome where hemolysis starts soon and she starts having higher bilirubin. So that is why it's very important to know how frequently you repeat them and how frequently you do these sonographies. So my question another is that if you're doing Doppler study, how frequently do you repeat it? I have seen people doing every day an ST. I have seen people doing twice an ST, doing Doppler every day.
Fortnightly, every 14 days it should be done instead of twice weekly.
Are you talking about normal Doppler flows or abnormal Doppler flows? You can't
wait for so much time. You don't have so much time of fortnight in such a patient, severe preeclampsia patient. We have to decide. So if it is Doppler is normal, then how would you repeat in these patients? If they are abnormal, how would you go for? You should know that those things.
So Dr. Poonam, do you want to respond to this? Then we can close it because the time is over.
Yes, ma'am. I think, ma'am, to tell the postgraduate, it's very important that doing an ST every day, every 6 hours, probably it is not really going to make a difference. We should stick to the recommended regimes and recommended investigation protocols. So doing every few days this Doppler study is not going to help unless you have an abnormal Doppler where you are seeing that your uterine flow is reducing or it is reversing. So that message has to go that these investigations should be repeated with the recommended protocols.
So I think it was well presented, quite limited. So we could not go ahead, but when a patient is not having any of those severe features clearly, and it is only the BP which is high, so I think a repeat BP would be advocated. And the patient should be started on antihypertensives and then take a call, because every week can kind of help you decrease the perinatal mortality and morbidity, but you have to be careful. I'm saying this is a patient where
one more thing I want
termination early. Yes, Dr.
add
Poonam.
was that ma'am, these students should also know that when we are talking about several drugs which are being started, so we must know all trials. There have been several trials where a very interesting trial, which is CHIPS trial, has said that the blood pressure, which was previously said that you keep it to 100 diastolic, now recommendation is that you should keep it to 85. So please look into these new trials, which are CHIPS trial, full plier trials. And there are a number of very interesting trials which have come where they talk about tight control of blood pressure or not so tight control of blood pressure. And last thing is that Indian guidelines say that our Asian women should be given antihypertensive at 150 by 100 as per Government of India guidelines, and not wait till 160, 110, because there were studies where, people had more of convulsions in these women. So those things also should be looked into. Thank you.
Thank you
And
so much.
in this patient, I would like to mention one thing, as she is 34 weeks only. We would like to start her with antihypertensives, and if it is controlled, you can, and if all our parameters, lab parameters and fetal parameters are okay, you can wait up to 37 weeks. Is there? I don't think so. There is any hurry to just terminate the pregnancy at this level, at these on these parameters. That is my opinion.
Yes.
Agree. Yeah. Okay. So thank you so much.
Thank you, Dr. Priya,
Well
for
presented,
nice case
Priya.
presentation. Thank you,
Thank you.
Dr. Poonam Verma ma'am. Thank you, Manjupuri ma'am. Thank you, Moshmi Tadas ma'am, for giving your precious time and judging this session and enriching our knowledge. Thank you so much, ma'am.
Thank you so much. Thank you.
So we'll move to our next session. As ovarian cancer is the third most common cancer in Indian women after breast cancer and CA cervix. And it goes undetected till it reaches the advanced stage, which is very difficult to treat and fatal. So it is very necessary to have proper clinical knowledge to diagnose and treat the same. So let's head to the next topic, which is on ovarian tumor by Dr. Pavandeep Kaur Saraf from MGIMS Savangi. And our faculty judges for this session are Dr. Vidyadhar Bangal sir, Dr. Anuja Bhalero ma'am, and Dr. Bhakti Gurjar ma'am.
Dr. Vidyadhar Bangal sir. He is a professor and head of the Department of Obstetrics and Gynecology, Ravara Institute of Medical College, Loni, Maharashtra. He has vast teaching experience of more than 31 years. He is a postgraduate teacher and examiner and also PhD guide. He is a member of Women's Task Force in international organization. He has N numbers of research publications in index journals, and he is a member of editorial board of 4 international journals. His areas of special interest are high-risk pregnancy, obstetric emergencies, community obstetrics, and medical education technology. He is also a president of Loni Obstetrics and Gynecological Society. We welcome you, sir. Next is our Dr. Anuja Bhalero. She is a professor and HOD of Department of OBGYN and NKP SIMS and Lata Mangeshkar Hospital. She is having vast teaching experience of more than 30 years. She is having done fellowship in urogynecology from Professor Shull, USA. She has received Best Teacher Awards and Best Research Award. She has been a faculty at various national and international conferences. And over all of this, she is the most approachable, great mentor with phenomenal leadership qualities. We welcome you, ma'am. Next is Dr. Bhakti Gurjar, ma'am. She is an assistant professor in Department of OBGY, IGGMC Nagpur. She has done FOXY recognized certificate course in advanced infertility treatment. She has 9 national and international publications to her credit. She has authored a chapter in a book, Practical Approaches of Menopause Management.
We welcome you, ma'am.
We welcome you, ma'am. So over to you, Pavandeep.
Pavandeep,
Yes,
please unmute yourself and share your screen.
Yes, ma'am.
Pavandeep, are you there?
Yes, yes, ma'am.
Start presenting your case, Pavandeep.
Yes, ma'am. Good morning, ma'am. My case is CA ovary. And, so let's begin. My patient
do not start with the diagnosis.
Yes,
Hello.
sir.
Yeah.
Yes, sir. My patient 60 years old, P2L2A1 with lump in lower abdomen, probably ovarian tumor with a possibility of malignant nature. My patient, Mrs. ABC, 60 years old, P2L2A1 with history of normal delivery post-menopausal. She's from X5 village, studied up to 9th standard, who is working as a maid belonging to class 4 of socioeconomic status came with chief complaints of lower abdominal distension for past
Sorry
2
to
months.
interrupt. Sanchita, make Shraddhara host.
Patient was apparently all right 2 months before when she gave a history of abdominal distension, which was gradual in onset, progressive in nature, and not associated with abdominal pain. There was history of feeling of heaviness in the lower abdomen for past 2 weeks.
Sorry to interrupt you.
Yes,
Sorry to
ma'am.
interrupt, judges. Your voice is echoing. So have you logged in from 2 devices?
No, ma'am.
Your voice is echoing. Okay, go ahead.
Okay, I'll check. Patient had history of vomiting for 1 day. That is approximately 1 week before. No history of difficulty in voiding of urine, no history of constipation or altered bowel habits, no history of menstrual disturbances, no history of mass descending per vagina, no history of discharge PV, no history of breathlessness, chest discomfort, no history of pedal edema, no history of jaundice and backache, no history of loss of appetite and loss of weight. Menstrual history, she attained menarche at 14 years of age. Her past cycles were regular, which were 5 to 6 days out of the 30 days period. She's postmenopausal since 8 years. She's married at 26 years of age to Mr. DEF, who expired at 8 years before in a road traffic accident. Non-consanguineous marriage, no history of oral contraceptive use, no history of infertility treatment. In obstetric history, she conceived after 6 months of her marriage, where she aborted at 2 months and evacuation was done at private hospital. And then she had her first pregnancy, delivered 2.5 kg normal weight baby. Her antenatal and postnatal period was uneventful. She breastfed her child for 2 years. Now the child is 26 years old. Her third pregnancy, she delivered male child of 2.5 kg, now 24 years old. During that, antenatal and postnatal period was uneventful. Postpartum sterilization was done after 3 days, and she breastfed for 2 years. She's a known case of type 2 diabetes mellitus for past 3 years on oral hypoglycemic agents. No history of hypertension, asthma, tuberculosis, renal or cardiac diseases. History of shoulder dislocation following roadside accident 8 years back, reduced under general anesthesia. History of carpal tunnel syndrome, right hand, for which surgery was done 2 months back. No history of blood transfusion or any drug allergy. No history of ovarian, breast, gastrointestinal, endometrial malignancies in the family. No history of diabetes, hypertension, coronary artery disease in family. She's on mixed diet. Her bowel and bladder habits are normal, non-smoker. She studied up to 9th standard. She is working as a housemaid, belongs to class 4 socioeconomic status. On general examination, poor built and poorly nourished. Height, her height is 160 centimeter, weight 50 kg, BMI is 19.3, according to which she is underweight. Pallor present, cyanosis, clubbing, icterus, and pedal edema absent. No lymph nodes were palpable.
Lymph nodes you want to
sorry, ma'am.
Hello.
Yes, ma'am.
You said no lymph nodes. Which lymph nodes you are referring to?
Ma'am, supraclavicular, left side supraclavicular lymph node, axillary lymph node, ma'am, inguinal lymph nodes were not palpable during.
दिखेगा ना, मेरे सारे friend भी देख रहे हैं अगर तुमको पता नहीं है. Everybody is watching. They'd like to किधर थी?
Yeah, continue.
Yes, ma'am. Her pulse rate was 80 per minute. Blood pressure was 130/80 mm of mercury in right arm sitting position. Respiratory rate is 20 per minute. She's afebrile. On systemic examination, breast and thyroid were normal. Spine and gait normal. CVS examination and RS examinations were also within normal limits. Central nervous system examination shows no focal deficit. Abdominal examination, on inspection, abdominopelvic mass was present. Fullness in flanks were present. Umbilicus normal in shape, inverted. Suprapubic transverse tubal ligation scar was present. No dilated veins and sinuses seen over the abdomen. On palpation, mass of 26 weeks corresponding to 26 weeks gravid uterus of size 18 into 14 centimeter in dimension. mid-placed with firm in consistency, mobility restricted, irregular surfaces and irregular margins were found. On palpation, there was no organomegaly, no tenderness, but there was fullness in flanks and moderate ascites was present. On percussion, there was dull note over the mass present and the shifting dullness was positive. Auscultation, bowel sounds heard and no brew was there. On bimanual examination, mass of 18 into 14 centimeter was felt, which was probably arising from the right fornix. Uterus was felt separately from the mass and is of normal size. Mass is of firm in consistency, irregular in surface-wise, mass was irregular, and the cervical movement is not transmitted to the mass. Nodularity was present in the posterior fornix. During rectovaginal examination, rectal mucosa was free. There was no nodularity and deposits in the pouch of Douglas. And the above findings were confirmed during rectovaginal examination. On per speculum examination, cervix healthy, vagina healthy, and there was no discharge or bleeding found during.
You do
and,
a examination, Pavandeep, after a PV examination?
Ma'am, per speculum examination was done and followed by perivaginal examination.
So
firstly, we
have written it at the last.
Yes, ma'am.
Hello?
Yes, ma'am. Yes, ma'am.
What information do
Yes,
you
ma'am.
get on per speculum examination in patients with ovarian mass?
Ma'am, her cervix and vagina was healthy and pap smear was taken and there was no discharge and bleeding present.
What other information do you get if there is a mass in the abdomen? From position and everything that on
yes, ma'am. Ma'am, if there are any other associated endometrial and CA cervix, which may extend up to the vagina or lower cervix involvement, then can be ruled out. And polyp or ma'am, if there is infections, if there is infections that associated, like PI, like in PID or bacterial vaginosis cases, that can be ruled out during perivaginal examination.
Pavandeep, there are so many things that you can notice on per speculum examination. Most importantly, the presence of rugosities, the position of the cervix. You can see if what is the color of the vagina.
Yes, ma'am.
There is any discharge, and there are so many things which will help you in coming to a diagnosis in patients with an ovarian mass.
Yes, ma'am.
Okay, continue.
Ma'am, provisional diagnosis, 60 years old female, P2, L2, A1 with lump in lower abdomen, probably ovarian tumor with possibility of malignancy, malignant nature.
Why probably an ovarian tumor? You said there's a mass in the adnexa, the uterus is felt separately. You
Yes,
have a possibility in your mind that there can be something else?
Ma'am, since there is ascites, then possibility of further GIT tumors like or any other pedunculated fibroid can be there. So, but since it is associated with weight loss and ascites, chances of malignancy are more, and there is a sudden increase.
Mobile, no? You said it's the
yes.
The mobility is restricted.
Restricted, yes, ma'am.
So, you said there is a nodularity in pouch of
Douglas. Yes, ma'am.
So still you have a thought in your mind that it can be something else?
Ma'am, looking at age, there are chances of malignancy, but since it is only diagnosis based on clinical examination, and further confirmatory will be histopathologically. So, yes.
And what are the various symptoms and signs that are telling you that this can be of a malignant nature?
Ma'am, patient has a history of weight loss, and she's cachexic, and ma'am, age, and ma'am, she's and mass in a postmenopausal woman. Plus, there is, ma'am, on examination, there is nodularity is felt, and ma'am, uterus is separate, so adnexal malignancy can be there.
So there are so many features which you have told us, which are going in the favor of a malignant nature of the mass. Okay.
Yes, ma'am.
So how will you proceed now?
Ma'am, we will admit the patient and will go for routine investigations. Firstly, we will proceed for tumor markers and transabdominal sonography. And after that, we will proceed with TVS if required. And then
which tumor markers you want to do?
In tumor markers, since the patient is of 60 years old, I'll go with CA 125, as in 60 years old with postmenopausal, there are chances of epithelial ovarian malignancy.
Yeah, tell us about the various tumor markers you want to do. Which are the newer ones? Which are the recent ones?
Yes, ma'am. Ma'am, CA 125 is done for epithelial malignancy. CA 19.9 for mucinous epithelial malignancies, and ma'am HE4 for epithelial again for epithelial cancers. And ma'am, there are new markers like ma'am OVA-SURE, which includes IGF-2 macrophage inhibitor factor, CA 125, and ma'am, it also includes
okay, so one thing that you're going to do is tumor markers.
Tumor markers. Ma'am, other markers will be for ruling out GCT, ma'am, inhibin B, inhibin A, anti-Mullerian hormone.
These tumor markers you want to do in this patient, a 60-year-old lady?
Basically, ma'am, CA 125, CA 19.9, and ma'am.
Under what clinical circumstances would you do inhibin levels of this patient? You said this patient has only non-specific GI complaints. So under
Yes,
what circumstances, if she had some additional complaints, then you would probably think of doing serum inhibin levels.
If it was associated with abnormal uterine bleeding, and if she had not attained her menopause till date.
But she is menopausal, so if she had postmenopausal bleeding, then probably you would think of this.
Yes.
Any other condition that you would think of if she had bleeding?
Yes, ma'am. Hormone secreting tumors can be there.
Yes, that is one.
Yes,
it could be a GCT, secreting hormones. That is one possibility. Any other possibility that would come to your mind?
Ma'am, there can be local causes.
No. Considering that she has an adnexal mass and bleeding.
Ma'am, she can have fibrosarcoma, where she will have AUB, granulosa cell tumor, and she can have fibroma, or
sometimes endometrioid types of
epithelial
are
cancer,
associated
yes,
with concurrent primaries in the endometrium.
Yes,
so those patients may have bleeding. An ovarian mass with bleeding should alert at least two conditions: GCT and a concurrent primary in the endometrium.
Synchronous tumor, yes.
Synchronous tumors.
Yes.
So you also said that there is no familial history of any cancer. So can you just elaborate on that? Which familial cancers are you talking about?
Ma'am, if there is a mutation in BRCA1 and BRCA2 gene, Lynch 2 syndrome, and ma'am, other syndromes like Maffucci syndrome, Olier's disease, Peutz-Jeghers syndrome,
so normally what familial cancers are common with Lynch or HNPCC?
Ma'am, colorectal carcinomas, ovarian cancer, and endometrial carcinomas, and breast carcinomas.
Okay, which type of ovarian cancers?
Ma'am, epithelial type of ovarian cancers.
And what about you said Peutz-Jeghers syndrome? What is it associated with? Which type of ovarian cancers are associated with that?
Ma'am, it is associated with hormone secreting tumors.
Anything in specific? So it is associated with sex cord stromal tumors, especially annular patterns.
Annular
These
patterns.
patients will also have hematomatous polyps in the
Polyposis.
GU,
Intestinal
and
hematomatous polyposis.
cancer of pancreas, colon,
Pancreas,
and all these,
yes.
right?
Yes, ma'am.
Okay, go ahead. So we were discussing how to investigate this patient.
Yes, ma'am. Ma'am, after tumor markers, various scores are used depending upon the tumor markers along with imaging modality. And we will do TVS, transabdominal sonography. If required, CT, MRI, PET scan can be done. And IVP to see the.
So you have to be specific. So you have everything. Everything is available to you. So what will you do? Ultrasound, CT, MRI, or PET?
Ma'am, yes, ma'am. Transabdominal yes, ma'am. Transabdominal sonography will see whether to differentiate between benign and malignant, and to see liver involvement, spleen involvement, lymph node status, and dimensions of the mass. And
what ultrasound features will make you suspect that it's a malignant tumor?
Ma'am, if during sonography we found papillary projections, septal wall thickness, cyst wall thickness more than 3 mm, and increased blood flow that is due to neovascularization, and on Doppler decreased RI and PI index, and plus ascites on sonography, neovascularization.
Okay. Anything
papillary
more?
projections.
And
multilocular, solid
populated cysts. Okay.
solid ecogenic regions. Yes,
so do you have an ultrasound report of this patient?
Yes, ma'am.
What was it?
Ma'am, it was suggestive of a solid cystic lesion of 18 into 14 centimeter arising, probably arising from the right ovary, extending, occupying the pelvis. And associated with ascites was present. And
so this patient, this particular lady had a solid cum cystic tumor. So are
Yes,
there
ma'am.
any tumors which are predominantly solid?
Yes, ma'am. Brenner's tumor, Krukenberg tumor, thicoma, fibroma. These are solid tumors.
Okay. And this patient had a unilateral tumor or a bilateral one?
Ma'am, unilateral.
Unilateral. So that goes more in favor of epithelial or non-epithelial?
Ma'am, that ma'am, usually serous type of are bilateral, but mucinous can be unilateral.
What percentage are bilateral?
Ma'am, 40% of serous type are bilateral, and in mucinous only 10% are.
40% are bilateral. So can you just enumerate some tumors which are more commonly bilateral? One is serous. Other you said is mucinous can also be bilateral. Any other tumors which are bilateral?
Dysgerminoma, ma'am, can be bilateral.
Are bilateral, right?
Krukenberg tumor.
Krukenberg's, right?
Yes, ma'am. Or
right.
And ma'am, other mainly except yolk sac tumor, germ cell tumors are usually bilateral.
Yeah, that's right. Over to you, madam. Ma'am, you were asking something?
Hello, may I ask you something?
Yes, sir.
Yes, sir, please.
Yeah. Now, she's a 60-year-old lady with ascites and 26-week size tumor.
Anji.
What is the differential diagnosis for this? Something you are missing in there's no discussion on that. As a postgraduate, we must think about those conditions. Just to enumerate what has not been mentioned in this discussion. 26 weeks, ascites, tumor in the pelvis.
So differential diagnosis includes, there can be full bladder, there can be severe endometriosis, endometrioma mass, and can be loculated ascites.
With what?
And
What would be the primary for that loculated ascites? Primary etiology.
Any GIT malignancy can be there.
We are missing abdominal COX.
Abdominal TB. Yes, sir.
Okay.
Abdominal COX with ascites.
Yeah.
Plus age.
Yeah.
Goes towards
Loculated ascites or maybe all the omentum gathered together. That may. So abdominal COX must be kept in mind while we are dealing with these women with ascites with some mass, vague mass in the lower abdomen, abdominopelvic mass. Okay. Anything else that will come to your mind? Can you tell me something about misfit tumors? Or not the misfit, this our ascites with Meigs syndrome.
Meigs syndrome. Yes, sir. In Meigs syndrome, ovarian tumors like fibroma, thecoma, and Krukenberg tumor are associated with Meigs syndrome. There is ascites, ovarian tumor plus right side pleural effusion. Right side pleural.
Meigs have particular criteria. Meigs and pseudo-Meigs are different. Okay.
Yes.
I'm asking about Meigs.
Sir, as fibroma of ovary. It is associated with fibroma of ovary.
With ascites with
right side pleural effusion.
Yeah. And then what is pseudo-Meigs?
Component is that it goes off after you remove the mass.
It regresses after surgery.
Talking about Meigs.
Pseudo-Meigs?
Yes, ma'am.
Pseudo-Meigs?
Any other ovarian tumor except fibroma like Krukenberg and dysgerminoma if associated with.
Okay. Well, few comments rather. While you speak, see that you don't use any short forms while either writing or maybe while speaking during postgraduate exams. Okay.
Yes, sir.
Like in a PPT, you write introduction as intro.
Yes, sir.
Okay. So those things are not liked by the assessors. So please see that. Then local examination, maybe local genital examination should be a part of the postgraduate examination. Don't start as Dr. Anuja has found out. Sequence is also important. Maybe you might have added that. Once we write the history and examine and put the points in the paper, again go through the history again, whether all the points are what you are going to tell are collaborating or matching with your examination findings or not. If something is not, again, you should find out. Is it right finding or a wrong finding? Okay. So, and sequence is also important. Per speculum should have come earlier. Before that, local examination of the extra genitalia. That also needs to be added. Okay.
Yes, sir.
And in per rectal examination, maybe whatever is failed, you're told whatever is not failed, but maybe anteriorly there may be some mass or uterus or cervix that we will feel. Not only in this case, but even in CA cervix.
Yes,
okay,
sir.
We do per rectal examination and findings must be noted accordingly.
Yes.
Okay. So that is something which I wanted to tell you. And anything else? And don't, when you are presenting gynec case, don't say that she is a 60 years old female. Okay. So you need not talk about female. Just say that she is a 60-year-old woman.
60 years. Yes.
Okay.
Yes, sir.
Now, two questions. One of them is, how do you confirm the diagnosis of ovarian malignancy? Clinical, you have suspected, and imaging has supported your evidence. How will you confirm the diagnosis? Because you all know that unless we have a definitive evidence that it's a malignancy, we cannot proceed. Okay. Yes. As far as whatever therapy is concerned. So how do you confirm? Even this tumor, your case.
Sir, histopathological examination is confirmatory. Since patient has ascites, we can go for ascitic tapping, and later on, sir, we can do staging laparotomy, which is gold standard.
Ascitic tapping for cytological examination for malignant cells. Okay, sir, that would be a correct correct saying.
Yes, sir. Cytological examination. So staging
what
laparotomy.
Would be the color of the, if it's a malignancy, what color of the ascitic fluid will suggest that it could be malignancy? From color.
Sir, blood tinged straw colored.
Yeah, hemorrhagic. Hemorrhagic color. blood stain color. And what in other benign conditions you get different colors. Okay, but if it is specifically other than little trauma that is caused, but if it is a generalized hemorrhagic, then that is highly suggestive that it is malignant. Okay, so that is one. But many times we don't get cytology positive even in malignant cases. So how do you confirm?
So we can do staging laparotomy.
Indirectly, I want to ask you, what is the role of FNAC? Is there a role? Pros and cons?
Sir, cases which are unresectable, or if patient is unfit for surgery, then we can go for USG guided FNAC of ovarian mass, so that we can start her on adjuvant chemotherapy.
That is one. And secondly,
the advantage minimally invasive and minimally invasive. It is a cheap investigation.
Side of it.
Sorry, ma'am.
What about the spillage of the tumor cells in the peritoneal cavity with the puncture? What do you have to say?
So that will be there. Chances are there.
Are there. Okay. Intraoperatively, when you have opened the abdomen, tell us all those features which will be suggestive of malignancy.
When vertical incision is given, which is supraumbilical, and if ascites plus.
Right from counseling and how do you prepare a patient for exploratory laparotomy, staging laparotomy?
So, ma'am, all the pre-operative anesthetic investigations will be done, including hemogram for surgical fitness, hemogram, LFT, liver function test, kidney function test, ECG, chest X-ray, for the fitness and to look for metastasis.
Important aspects of counseling. What are you going to tell her?
Since on opening, disease can be unresectable, as in advanced diseases, and it may need advanced procedures like colostomy. So counseling should be based on that. And
so one is colostomy.
Okay. And if tumor is unresectable, open and close case can be there. Open and close.
Before opening her up, no? We would not be operating upon patients where you think that the patient would require a neoadjuvant chemotherapy. So in these patients, we will always give neoadjuvant first and operate upon them.
Neoadjuvant chemotherapy, then surgery, and then adjuvant chemotherapy.
Yeah. Sorry to interrupt you, ma'am, but we are running short of time.
What are the keys of staging laparotomy?
Intraoperative features. Yeah.
Ascites will be there. There will be, if visible peritoneal mets can be there, and omental caking can be there, and in ovarian mass, which may be solid or solid cystic, is present, and adhesions can be there, and on palpation, lymph nodes can be palpated.
On the tumor surface, what you will find, that is the first thing. After the hemorrhagic ascitic fluid, on the tumor surface, what you will find, that would be giving you some clue that it is malignant.
Vessels, prominent vessels and vessels will be there.
And in ultrasound, you already told. What is that?
Neovascularization.
That is one. Another is papillary projections.
Papillary projections.
Excrescence, as they call,
excrescence
on the surface. Okay.
Yes, sir.
Adhesions you have told. Variegated consistency.
Variegated consistency.
Bilateral nature of the tumor. Okay. And all other things which you have already said. Okay.
Yes.
So the name of the procedure is staging laparotomy. So what are the components of staging?
Ma'am, supraumbilical incision is given for better field and for palpation of all organs to look for metastasis, and then we'll obtain a fluid for cytology. If there is no fluid for cytology available, then we can give a wash with 50 to 100 ml NS, then collect cytology from retropubic space, then pouch of Douglas, right paracolli gutter, and then subdiaphragmatic face and left paracolli gutter, and then we palpation should be done in clockwise manner of all organs to look for metastasis. Uterus, pedicles, pouch of Douglas, ileum, cecum, ascending colon, hepatic flexure, and liver, diaphragm, transverse colon, and splenic flexure, spleen, and descending colon, sigmoid colon. All these structures should be palpated for in a clockwise manner.
Okay, so just like you discussed just now, the appearance is of a malignant tumors rather than a benign tumor. So what do you do now?
Procedure we will do is hysterectomy plus bilateral salpingo-oophorectomy plus infracolic omentectomy plus lymph node dissection.
But
cytoreductive surgery, debulking surgery.
We just discussed that we need to have a definitive diagnosis. On gross appearance, it looks like a malignancy, but do we have a proof? So can you go ahead with such a extensive surgery based on assumptions that it could be malignant? So can you do something else?
Frozen section can be sent.
Right.
Frozen section.
Okay. So if frozen section is positive, then you can go ahead with cytoreduction.
Cytoreductive surgery.
What is the other name for cytoreduction?
Debulking surgery.
Debulking.
Debulking is what you are going.
What is the aim of doing debulking? When we should attempt that?
Done in advanced cases, and aim is to remove as much as possible. We can remove tumor.
We are talking about optimum debulking. What is that?
If there is no visible gross lesion present or less than 1 centimeter tumor, microscopic tumor is left.
Less than 0.5 centimeters. And post-operatively, what you will do?
We will plan for adjuvant chemotherapy and delayed suture. We will go for delayed suture removal.
Okay, Pavandeep, your time is up and you've done well.
Yes,
but there are quite a number of things that you need to read also, like prophylactic salpingectomy, role of chemotherapy, radiotherapy in patients with ovarian masses, germ cell tumors, borderline ovarian tumors. These are very important questions that can be asked. And
yes,
for postgraduates, these are some of the take-home things that you need to read. Bhakti,
yes,
Bengal sir, you want to say?
Yes, I think Pavandeep, you have answered well, and you are passed from my side. So that's all I can say. Only thing is that in recent advances, you may get questions like the role of HIPEC and role of PARP inhibitors in ovarian cancers. So that also you should read. And you have presented well. Thank you.
Thank you.
You have presented well. Okay. All the best.
Thank you, sir. Thank you.
Thank you, Pavandeep.
Thank you, ma'am. Thank you,
This
ma'am.
presentation. Thank you,
Thank you, ma'am.
ma'am. Thank you, Bangal sir. Thank you, Bhakti Gurjar ma'am, for your precious time and judging this session and sharing your knowledge and guidance. Thank you. So we are shifting to our next session, which is table viva. And student for table viva is Dr. Priyanka from IGMC, Nagpur, and faculty for this session is Dr. Buhariwala ma'am. Welcome you, ma'am.
Dr. Buhariwala ma'am. She is the honorary professor in Department of OBGYN, NKP SIMS and LMH Nagpur. She is a former professor in HOD in NKP SIMS and LMH Nagpur. She is a former associate professor in Goa Medical College. She has been UG and PG teacher and guide and examiner for same. She has special interest in high-risk pregnancy, gynec cancer surgery and vaginal surgeries. We welcome you, ma'am.
Hello. Hello.
Dr.
Can you hear me?
Priyanka, are you ready?
Good afternoon, ma'am. Good afternoon.
So we are sharing our first spot for table viva.
Over to you, Buhariwala ma'am.
Acha. The other internet is not working, so I'm on my phone. And Priyanka, you can see whatever is on the screen for you. So can you just tell us something about what you see?
And it is the
Can you identify?
oxytocin injection. It is the uterotonic, ma'am, which is nonapeptide. Synthetic forms are pitocin and syntocin, which are decapeptide. It is used in the pregnancy for induction of labor and augmentation of labor and to control PPH after delivery. Then it is used as in high doses in primary, and it can be used in low doses in multi.
Any other indications in practice for pitocin?
For diagnostic purpose in non-stress test, contraction stress test, it is used.
Contraction stress test, which we hardly do. Non-stress test means there is no contraction. So that was not correct. Anyway, any other conditions? What are the things you said as far as indications is concerned? Can you repeat, please?
Induction of labor, augmentation of labor, and for control of postpartum hemorrhage.
Can you use it as a prophylactic?
Yes, ma'am. Prophylactic.
In active management of labor?
Management of third stage of labor, 10 units IM oxytocin is given.
In the early part of pregnancy, can you use it for some conditions? Or is it only in labor?
In second trimester, in third trimester abortion, second trimester abortion, it can be used. After section and evacuation of vesicular mole can also be used to control bleeding.
That's a very good answer. So supposing you are using it in vesicular mole, when will you start the pitocin?
After evacuating the uterus, you have to start.
After evacuating the uterus, because it's a very floppy uterus. It is a very floppy, thin-walled uterus, isn't it? So, when will you start the pitocin? Can you revise your answer? Why do you want to give it after the evacuation?
Chances of embolization is more in case of evacuation.
The correct answer would be that you should not give it before putting in the cannula. Earlier, people used to start the pitocin to dilate the cervix. That is dangerous. Once the evacuation is started, you can give, because already the outlet is there for the moles to come out. So embolization is minimized as well as bleeding is controlled. Anyway, let us go back to the term cases. You said induction of labor. All right. Can you tell us how you would induce labor and when?
Ma'am, induction of labor starts with physiological doses, ma'am. So low doses can be given like 0.5 units or 1 unit. For augmentation, it is given as 2 units or 2.5 units. For
induction, when will you give it in labor? To start with, what should be the status of the cervix, etc.?
Start when the cervix is one finger loose, adjust os closed in.
Is this what is recommended? Is there a better method of ripening the cervix for induction?
For induction, prostaglandins are better.
Yes.
Than oxytocin.
So what is your practice in your institution? Can you tell me?
We used to use misoprostol 25 for induction of labor.
Misoprostol, okay. So supposing you start with pitocin, is there any risk?
It can cause uterine.
What does RCOG say? What does RCOG recommendation tell us? Can we start pitocin? Is there any danger to the mother?
Uterine hyperstimulation can occur.
No. Initially, there is no hyperstimulation. But today we say after an ARM, you should use pitocin for its safety. Not earlier. There are chances of embolization, amniotic fluid embolization, which can be very dangerous. So it is much better to start with misoprost, let it progress, ARM, and it is more for induction, for augmentation today. All right, let us go to the third stage quickly. Third stage.
Third stage, immediately after delivery of first baby, Pitocin 10 units is given IM prophylactically.
Yes.
Um,
and in PPH?
In PPH, we have to give more doses like that, but 10 units or 20 units in 500 ml of NS or RL.
Okay, okay, all right. And what do you, all right. In labor, what do you observe carefully? When you give it for augmentation, what do you observe? If we go back to
for the contractions, a number of contractions and the time which each contraction persistence. The dose is increased every 15 or 20 minutes depending on the contraction. And the fetal heart rate should be monitored.
Okay.
And
what is hyperstimulation? Priyanka, what is hyperstimulation?
Greater than 4 contractions persisting greater than 40 seconds in 10 minutes.
Okay. And that's all? That is hyperstimulation? Then what is tachysystole? How does it differ?
It is the tonic contraction of uterus, which it is also the same, ma'am, greater than 5 contractions and no relaxation in between contractions.
Fetal heart also gets affected, isn't it? Okay. We have 3 more spots. So shall we go to the next one, which is prostaglandin? 250 micrograms. What do you have to say? What is prostaglandin or carboprost? What is it?
PGF2 alpha.
PGF2
alpha. It is also used to control postpartum hemorrhage. It is given as 250 microgram. It can be repeated up to 8 doses with 15 minutes interval.
Control of which type of postpartum hemorrhage? You should specify. No, you're a PGCON. Yeah. Be complete in your answer. Okay, then. So you can give 250 micrograms. And supposing it doesn't come under control, how soon can you repeat?
Every 15 minutes it can be repeated. Till 8 doses.
Till?
8 doses can be repeated. Till
8 doses. Okay. 8 doses. All right. All right. So up to 2 mg, you can give the patient. All right. Okay. What can be the side effects?
Side effects like diarrhea, hypertension, and bronchospasm. It is contraindicated in asthma and liver disease.
It is contraindicated in what conditions?
Asthma, liver diseases,
heart diseases,
cardiovascular disease.
Okay, okay, all right. And then we have the next spot, that is methergine. What is methergine? Can you tell us?
Methergine, it is a methyl ergometrin derived from Carviceps purpureum. It is also used to control postpartum hemorrhage. It can be given immediately after delivery of placenta in 3rd stage of labor. Methergine is.
Can it be given earlier also? Can it be given earlier also?
No, ma'am.
Only after delivery of the placenta, right? Is that so?
Yes, ma'am.
Can you give it? If you're very effectual, can you give it with the delivery of the anterior shoulder as we always practiced? That will be a better method of doing. If you give it after the delivery of the baby, what will happen?
It will causes tonic and contract, but this causes contraction of both upper and lower segment of uterus. So delivery of placenta may be.
So there will be a retained placenta. In short, there will be a retained placenta. Is methergine being used in your institute?
Yes, ma'am. But used cautiously.
As a routine, as we used to do in my days, with every labor we gave methergine unless it was really contraindicated.
In PIH patients and cardiac disease patients, it is not used, ma'am. Otherwise,
you're giving for all your patients?
Yes, ma'am.
You're giving for all your patients?
Yes.
No. Oh, because there is this thing that it could.
Sorry to interrupt you. We
Hello?
have another slide. Can we move to the next slide?
Mesoprost? Shall we go to mesoprost?
Yes, ma'am. Mesoprost.
Hello?
Yes, ma'am. Mesoprost. It is also used for induction of labor.
No. You just see the slide. What is written mesoprost? 600.
It is used
now you just restrict yourself to mesoprost 600 quickly and tell us what is its use.
It is used in medical termination of pregnancy, incomplete abortion, and missed abortion.
600 straight away you give in medical termination of pregnancy. 600 is designed for what?
It is in first trimester abortions.
It is designed for what? 600.
PPH. To control PPH.
For labor cases, isn't it? For labor cases. Why is it preferred over Pitocin? Can you tell me, mesoprost, in our country, to give you a hint? Hello?
Yes, ma'am. It
How
helps
is it preferred over Pitocin in our country for active management?
Is easily available.
Easily available?
In PHCs or rural hospital, 800 microgram is kept in.
You can make Pitocin available also easily. What's your problem? What is the main difference? It doesn't need to be
time of action.
Okay.
Ma'am, we have a next slide to cover. Can we move to the next slide?
Okay. So just one thing to tell you that it is heat stable. Okay. It need not be refrigerated, which may not be possible in a rural setup. Thank you very much. Shall we have the next slide? Okay. So can you identify the first half of the slide quickly?
It is iris spatula, endocervical brush. And
what third? Third is what?
Cytology brush.
Cytology brush. Is there any other name to this brush? Does it look like a brush, Priyanka? It looks like a broom. Na? So it is also called a cytology broom. All right. Okay. So these are all for pap smears, right? For cytology. Now, can you tell me the last one is utilized for what in particular?
Is colposcopy.
No. These three.
It is used for liquid cytology.
Sorry, it's not clear to me. What did you say?
Liquid-based cytology, ma'am, for pap smear.
Okay, liquid-based cytology. All right. So one is a conventional pap smear, other is a liquid-based cytology. Okay. Now, what is better and why?
Tell
us about pap smear everybody is doing. Let us talk a little about liquid-based cytology. How is it done? Quickly tell me.
Liquid-based cytology is better, ma'am. But in rural settings, it is difficult.
No, let us say per se it is better. You tell me why. Then we'll go to our country, our poor country.
It can be done during bleeding. If there is even bleeding, we can take sample, ma'am. Or in the same setting, we can send for HPV examination.
What is done? How is it done? Can you tell me the method?
The patient is in lithotomy position, ma'am. We have
no. Just what is done specifically? Tell me, quick. Patient is all ready for it. What do you do? You put in a speculum. Now what do you do?
Rotate it through both endocervix and ectocervix through 180 degrees, and we have to take the sample in the liquid-based media, and we sent for pap.
What sample? What is the sample?
Ethyl alcohol and ether.
No, the sample. What do you send in the bottle?
When we have to shake the broom in the sample, so the cells
you break it better and put the broom part into the bottle. Okay, close the bottle and send it. Okay, so that is liquid-based cytology. Now, can you quickly tell me when do you start taking a pap smear for a woman? Quickly. At what age and what is the protocol?
Should be started from the 21 years age. We have to, if it is negative, we will do it every 3 years. And co-testing and HPV examination will be done from 30 years and above.
So if you are doing it with HPV testing, how often is it recommended? You can do it after?
Every 5 years we can.
5 years. Until what age?
Till 65 years we can do, ma'am.
Can we stop at 65 years? Or there are some exceptions?
Negative in the last decade, then we can stop.
Very good. Anything else?
If it is in case of HIV patients, we have to do annually for the first 3 years, and then if it is negative, then every 3 years can be followed.
Okay, we'll finish it here. Let us go to the next one. We don't have time to elaborate on more things about the pap smear. Can you tell me the second half? What do you see in the second half of the slide?
Colposcopy fine.
Okay, and you see a colposcopy picture. Just in brief, what does a colposcopy do? What is its advantage?
Colposcopy, it is more specific than pap smear. And the advantage is it is both diagnostic and therapeutic. In the same sitting, we can do cauterization if any abnormality is there. And we can take histopathology from the same sitting.
We can take biopsies, directed biopsies, isn't it? We can take directed biopsies. Right. Now, how much does it magnify your colposcope? Can you tell me?
It magnifies from 6 times to 30 times magnification is there.
The usual ones? Around 15 if it is, it's to 30, 35. Okay. Now, in this particular slide, you are able to see a lesion on the cervix. What do you see and what is it likely to be? Tell me. Can you describe what you are seeing? What has been done now to the cervix? Anything has been applied?
Acetic acid is applied.
Percentage?
3 to 5% of glacial acetic acid is applied.
Acetic acid has been applied. Okay, now what does acetic acid do?
It coagulates the proteins which are present.
In pre-malignant conditions, the proteins are increased. All right. So how do they stain because of the proteins? How do they appear? Sorry, not stain. How do they appear?
The cells are dehydrated with the cells which contain high protein. So it appears white in color.
So that is aceto-white test, right? Now, supposing you see this white type of appearance even before applying this acetic acid, what is that?
Can be leukoplakia.
That could be leukoplakia. Anyway, here, obviously, acetic acid has been applied and you can see the lesion. Can you describe this lesion to me and then give your provisional diagnosis? Of course, biopsy will be the final thing, but can you give me a provisional diagnosis? Describe first. What do you see?
The pink color outer cervix, which is the ectocervix, lined by squamous, and the generally endocervix is red in color, which contains columnar epithelium. In junction between them is the transformation zone.
Sorry to interrupt you, ma'am, but we are running short of time. So can we please summarize the things from exam point of
The
view?
normal transformation zone.
This is a normal transformation zone, you think?
Yes, ma'am.
Okay. We'll just summarize quickly whatever we have done. Okay.
Yes.
As far as the uterotonics are concerned, we discussed 4 drugs, right? And if one says which is the most effective, it is still our age-old methogen, which is the most effective. But we have got various other drugs today, and they have been sort of highlighted today. Then we have talked about pap smears, when to do a pap smear, and what should be the protocol, etc. What is the preparation before, or what should we see to as far as the patient is concerned before we do a pap smear? There should be no infection, local infection, that must be treated. Otherwise, the report will come as infection and you will have to repeat it. All right. There should be no intercourse 1 day prior. There should be no use of any local gels, etc. So carefully, properly done pap smear is very important. LBC is definitely preferred because it removes the blood and the mucus, and you get a very thin film which can be studied well. We did not have time to discuss the various types of changes that we see and the various classes in a short span, so we couldn't do that. And of course, colposcopy is a very, very important thing that can be done today. And what is the advantage of colposcopy? We can treat, and it minimizes the need for cone biopsies today. Thank you so much, Priyanka. You answered well, and I wish you all the best.
Thank you.
Thank you, Priyanka, for nice table viva. And thank you, Dr. Buhariwala ma'am, for your precious time to judge this session and sharing your knowledge and guidance. Thank you so much, ma'am.
Thank you. Thank you very much for having me.
Dr. Akansha Priyam, she's from GMC Nagpur, and our faculty judge is Dr. Kothalkar ma'am. Dr. Anjali Kothalkar, she is a professor in Department of OBGYN NKP SIMS. She is a AHA approved BLS, ACLS provider and instructor, and AAFP approved BLSO, ALSO instructor. She has done postgraduate diploma in medical law and ethics as additional qualification. She has a vast teaching experience of more than 30 years. She is involved into medical research with 30 publications in various medical journals. Her hobbies and passions are birdwatching, photography, painting, and philosophy. We welcome you, ma'am.
Thank you so much.
Slide for the next presenter is
Hello.
Dr. Priyam. Dr. Priyam.
Hello. Am I audible?
Akansha, are you there?
Yes, I'm here. Ma'am, am I audible?
Unmute yourself.
I've unmuted myself. Ma'am, am I audible? Hello.
Akansha, can you hear us?
Yes, ma'am, I can hear. Am I audible?
Yes, you are.
Okay. Thank you, ma'am.
So we'll start with your name, please. Who is present?
I'm Dr. Akansha Priyam, JR3 from Obscany Department of GMC Nagpur.
Okay. So Akansha, isn't it? So,
yes, ma'am. Good afternoon, ma'am.
So we start with it is like a mock table viva for you. And on screen, what can you see?
Akansha?
Yes.
What can you see on the screen?
And the screen is not visible.
Screen is not visible now? Is it visible? Because it's visible to me.
We are unable to hear them. We are unable to hear them.
Ma'am, the screen is not visible.
Screen is not visible. So let us should I tell you what is on the screen?
Yes, ma'am, that would be helpful.
There are 21 tablets with 7 red tablets. What do you think it can be?
It can be, ma'am, oral contraceptive.
28 total tablets, 21 are white and 7 are red.
Ma'am, it could be oral contraceptive pills.
What type of oral contraceptive with the 7 red tablets?
Ma'am, combined oral contraceptive.
Combined, we have so many, isn't it? With the 7 red,
Ma'am,
what are these?
Ma'am, it could be Mala N or Mala D.
Yes, very good. So what is the content of Mala N?
In Mala N, we have ethinyl estradiol and levonorgestrel. Ethinyl estradiol.
How much?
Ma'am, ethinyl estradiol is in the it's in 30 microgram and the levonorgestrel is 0.15 milligram.
Okay. So that is one. What is the difference in Mala N and Mala D? Akanksha?
Ma'am, Mala N we get free of cost, while as for Mala D we have to pay a nominal charge of 5 rupees.
Yes, that is, but both are supplied by government. Isn't it? Can you tell some of the non-contraceptive indications for this?
Ma'am, it is given in cases of menorrhagia, and it can also be given in the dysfunctional uterine bleeding.
Okay, that is one and the same, I think.
Yes, ma'am.
And any other indication you can think of?
We can also give it in to decrease the perimenopausal symptoms, and it can also have beneficial effects in preventing endometrial cancer and preventing hormonal imbalance problems like acne and hirsutism.
Okay.
And in PCOD.
Okay. Any additional health benefits are there apart from the contraception? When suppose a patient is taking it regularly for 1 to 2 years, what are the additional health benefits a woman gets when she is taking this as the method of contraception?
Ma'am, there is a regularization of the periods, and it causes also, as it causes it treats all the irregularities. People are less prone of having anemia, and
Yes,
and they have lower
prevention
risk of
of
having any kind of benign breast diseases and lower risk for ovarian cancers.
Okay.
And also some psychosexual problems like depression and loss of libido can be overcome.
As an additional health benefit? This is the additional health benefit?
Yes, ma'am. Lower risk of benign breast diseases, lower risk of endometrial cancers and ovarian cancers, and also lowers the risk of fibroids.
Can you see the screen now, Akanksha? Is it visible to you?
Sorry, ma'am, I'm not being able to see the screen.
You are not able to see the screen now?
No, I can see you, but I cannot.
Now I will describe the next one. There are 8 tablets, and the name given is Saheli.
Oh, okay, ma'am. Okay.
The script, and there are 8 tablets. White tablets are there. What do you think it is?
8 white tablets, and the name is, ma'am, is it Centroman?
Yes, correct. So how much is the dose for Centroman if you want to give it as a contraceptive? How much you will advise?
Ma'am, it is taken as twice a week for first 3 months, 30 milligrams, and once a week for the next 3 months.
Okay. What type of, whether it is a steroidal or hormonal or non-hormonal contraceptive? This one,
non-steroidal, non-hormonal contraceptive. It is
non
a selective estrogen receptor modulator.
Wow. Can you give it in a lactating patient?
Yes, ma'am. It is safe in a breastfeeding woman.
And what about our previous one, Mala and Maladi? Whether you will advise Mala and Maladi in a breastfeeding woman?
No, ma'am.
Why not?
Ma'am, it is known to decrease the amount of breast secretion, and also it is secreted in the breast milk.
Now, what do you mean by low dose OC pills, and what do you mean by ultra low dose OC pills?
Ma'am, in these the amount of estrogen varies. In low dose, it is 20 microgram. In an ultra low dose, it is 10 microgram.
Mala N is what? Then? Because you said it has 30 microgram, isn't it?
Yes, ma'am.
Low dose is 20 and ultra low dose, how much you were telling?
Ma'am, ultra low is less than 10 microgram.
10. If you go to 10, what will happen? If you really give 10, there is a limit to how much we can reduce the content of the ethynyl estradiol in the OC pill. If you reduce it too much, which complication is likely to be there? For example, you give it up to, as you say, 10. What will happen?
Ma'am, the 10 is the lowest possible dose that is given.
Which complication will be more likely to be there with the lowest possible?
Sorry, ma'am.
So the complication is breakthrough bleeding. And what you said is wrong. Low dose is 30 microgram Akanksha and ultra low dose is 20 microgram. Okay.
Okay, ma'am.
Whatever we give, that is 30. That is low dose. That is not more than low dose. That is low dose OCP.
Okay, ma'am.
Majority of the OCPs are having 30 and these are all low dose. Whatever is less than that, that will come under the ultra low dose.
Okay, ma'am.
Third is the injection and it is written as Depo-Provera on it.
Yes, ma'am.
So what is it on the screen?
Ma'am, it is a form of injectable contraceptives.
Which drug is there?
Depo-Provera, ma'am, you said it's a kind of a DMPA, depomedroxyprogesterone acetate.
Yes. How much is there?
Ma'am, it's 150 milligram per ml and it's given as intramuscular dose.
How frequently?
Ma'am.
To be repeated after interval of how?
3 months.
3 months. Now, suppose a patient fails to come exactly after 3 months. So, how much is the window? How early she can receive it? She wants to go suppose she wants to go somewhere else. How early it can be given or how late it can be given? Today, suppose for example, today is the date of the patient. Today is the date. She is supposed to come for the next injection today.
Okay.
So how early and how late it can be given? Any idea?
Ma'am,
it can be given 2 weeks early or it can be given up to 4 weeks after the date.
Ma'am, safe period is 4 weeks by WHO and CDC says 2
Suppose
weeks.
she comes even after 2 weeks, 3 weeks, it can wait.
Yes,
okay. What is the name which is supplied by the government of India? The same preparation. What is the name of the preparation which is supplied by government of India free of cost? DMPA.
Antara.
And what is the name for Sencroman which is supplied free?
Ma'am, it's Chaya and Saheli.
Great. You are doing so well. Can we go to the next lot?
Yes, ma'am, but sorry, ma'am, I could still not see what is on the screen. I don't know why it is coming.
What we have discussed is the combined OCP, especially Malign. We have discussed Sencroman and we have discussed about DMP. Out of these three, which are safe in a patient who is lactating, that is clear to you?
Yes, ma'am.
You can give to lactating?
Yes, ma'am. Sencroman we would give in
and what about DMPA?
DMPA, ma'am, we can give.
No. Any other long acting injectable progesterone preparation whether you are aware apart from DMPA?
To be given, ma'am, to be given in lactating women.
Yes, to be given in lactating, which is the other progesterone preparation. Injectable long acting.
ओव्हन मध्ये पावर ना किती वेळ करायचं असतं
Hello. Akanksha, you are with me?
Yes, ma'am. Yes, ma'am.
Other preparation is net in. Just find out about it. And what you should know as a postgraduate is why we have stopped using net in and why we are mostly using DMPA. What is the difference between the two preparations and what are the complications? More complicated. What are the things which are there with net in, and so we have shifted from net in to DMPA. Excellent. Sayukta, can we go to the next slide?
Yes,
Am I audible to you, Sayukta?
Yes, ma'am. Yes.
So we have discussed the first one. Unfortunately, she cannot see the screen.
This is the next slide.
Next one. Yes, this one. We have discussed about the contraceptives and now we are coming to the other, but she cannot see the screen. Can you do something about it?
Dr. Akanksha, can you see the screen?
No, ma'am, I cannot see the screen. I'm really sorry.
Okay, again, I will start in the same manner for you, Akanksha, then.
Is everyone else is able to see the screen?
We don't waste time. I will just read out whatever is seen on the screen.
Everyone else is able to see her screen.
Doesn't matter. We will
Can you
continue.
please come to a place where there is a good network and good visibility of the slides? Is there any?
Ma'am. Ma'am, yes, I can see the screen. The first.
Akanksha?
Yes, ma'am, I'm able to see the screen.
Now, tell me what are the drugs which are on display?
Yeah, the first drug is nifedipine slow release.
Kothalkar ma'am, can you please ask her questions, taking the names of the drugs?
Ma'am, I am able to see the screen.
She can see now. She says she can see now. So first is a nifedipine, second is?
Second is magnesium sulfate.
And
third
one?
is atosiban, and the fourth one is dexamethasone. Vial.
So with the group of these four together, what do you think is the common condition which we are thinking about?
Ma'am, we can use this in preterm labor.
Preterm labor. So what is the aim of giving topolytics in preterm labor? What is main aim? As an obstetrician, whenever we are giving topolytics, what is our aim? What is our goal of using topolytics?
Ma'am, we want to prolong the pregnancy as we want to reduce the neonatal mortality and morbidity, because
suppose a patient comes at say 30 weeks.
Yes, ma'am.
Then
we also want to get adequate time so that we can cover the steroid coverage for the fetal lung maturity, so that even if there is
one, that is one, agreed. Your first indication, that is there is a question mark now in the modern obstetrics. Whenever we are using topolytics, it is not to prolong the pregnancy, but mainly to give advantage of steroid to the baby. Second advantage, we want few days in our hands. One is for the steroids to take have the action. Second, suppose a patient is going to a primary health center.
Ma'am, second, ma'am, we can also give for the neuroprotection of the baby, neuroprotective.
Neuroprotection, okay. And so you want the intrauterine transfer to a place where all the facilities are there, isn't
available?
It?
Yes, ma'am.
So you need time for that also. So you give topolysis.
Yes, ma'am.
Out of all these drugs, which one you will prefer as a first drug of choice if you get a patient of preterm labor?
Ma'am, I would prefer nifedipine.
Why?
Ma'am, because it is easy to administer and it is easy to monitor also.
As compared to what? As compared to which drug you are talking about?
Ma'am, I'm comparing them to beta agonist drugs, and
is there any role of beta mimetics in modern obstetrics as topolytics?
Ma'am, yes, ma'am. We use drugs like ritodrin and isoxsuprine, whose drug have to be given in a very monitored fashion, and they
what is the main disadvantage of those drugs?
Ma'am, it leads to maternal tachycardia and hypotension, and many times headache, and also flushing. So,
So more of a cardiovascular complications, pulmonary edema can be there, isn't it? Even life-threatening
edema, yes, ma'am.
And we have literally stopped using those drugs because we have better drugs available with us, isn't it?
Yes, ma'am.
What are you using at your institute?
Ma'am, we are using Nicardia, and we are also using magnesium.
What is the dose you are giving?
Ma'am, we are giving at 10 to 20 milligram at TDS or QID dose.
You are not giving loading dose?
Loading dose, ma'am, 20 milligram is given.
Okay, so your first drug of choice is nifedipine. Why not indomethacin?
Ma'am,
your choice with indomethacin.
Ma'am, indomethacin is it's a COX inhibitor, so there are some complications like closure of the ductus arteriosus in the baby.
Very good.
And
oligohydramnios.
And yes, ma'am, it can also
oligohydramnios. It can lead to oligohydramnios also.
And GI bleed and decreased urine output and renal injuries are somewhere reported with this.
Whether you have used atosiban?
Yes, ma'am. There were a few trials about a year ago in our college where atosiban was in the trial study.
What is its main mechanism of action?
Ma'am, it is oxytocin receptor antagonist.
And how much? What is the dose?
Ma'am, 330 milligram over 48 hours it is given. We give a bolus.
330.
Yes,
that is the maximum.
Maximum.
But how you start? How much? Any idea? Because you said you have already seen using it. That is why I'm asking you.
Ma'am, a bolus dose of 0.9 ml IV is given. And then 300 microgram per minute IV infusion is given for the 3 hours. And for next 45 hours, it is 100 microgram per ml per minute.
Now, suppose there is no, how much is the cost? Are you aware?
Ma'am, around 5,000 to 6,000.
Yeah, so that is the most limiting factor for us, isn't it?
Sorry to interrupt you, ma'am.
There is no such limitation, and both are available freely, atosiban and nifedipine. Which one is more effective? What are the studies, recent studies? What is the evidence?
Ma'am, I have not much insight into this, but it's atosiban.
Nifedipine is the few studies are emerging, and the evidence is emerging that nifedipine efficacy is more as compared to atosiban. So first drug is nifedipine, and whenever nifedipine also is contraindicated, then you must go for atosiban.
Sorry, Kothadkar ma'am, but we are running out of time. Can we please conclude things and...
Yes. So Akanksha, done well. All the best to you. Both the group of drugs you have done very well. And the only thing is what message to all the postgraduates is, whenever there is a drug, you should be very well aware about the mechanism of action, dose, indications, contraindications, side effects. That much for each drug you all prepare, so that it is almost like getting 100 out of 100 marks if you know all these things about the drugs. And on table viva, you can score and you can compensate whatever in the case. Suppose you have not done that well, don't get disheartened, because table viva is the opportunity where if you prepare for each drug in this way, it will help you. You will almost score 100%. Well done, Akanksha. Thank you. Thank you, Sanyukta.
Thank you so much.
Thank you, Akansha. You did very well. Thank you, Kothadkar ma'am, for enlightening our knowledge and giving your precious time to judge this session. Thank you, ma'am.
Most welcome.
So we'll move to our next session. Pregnancy with previous scar is one of the dilemmatic condition for an obstetrician. Hence, it is very certain to discuss this condition. Our next case presentation is on pregnancy with previous LACS, and the presenter is Dr. Neha Kamble from IGMC, Nagpur. And our faculty judges are Dr. Alka Patenkar ma'am, Dr. Mugdha Zungari ma'am, and Dr. Surekha Khandale ma'am. Dr. Alka Patenkar ma'am. She is an associate professor in Department of Obstetrics and Gynecology in IGGMC Nagpur. She has been trained in prenatal diagnostic technique from ICMR Mumbai. She has conducted around 450 chorionic villus sampling and amniocentesis for prenatal diagnosis of sickle cell hemoglobinopathies and thalassemia in GMC and still doing it. We welcome you, ma'am.
Good afternoon.
Good afternoon, ma'am. Coming to our next faculty, Dr. Mugdha Zungari. She is an associate professor and head of the department in Datta Meghe Medical College, Vanadongri, Nagpur. She is a practicing consultant obstetrician and gynecologist, infertility specialist, and laparoscopic surgeon at the Purple Women's Healthcare Clinic. Her areas of interest are high-risk pregnancy, non-descent vaginal hysterectomy, and PCOS. She is a life member of PCOS Society in India. She has 18 research articles in national and international journals. We welcome you, ma'am. Our next faculty is Dr. Surekha Khandale, ma'am. She is an assistant professor in IGGMC Medical College, Nagpur. She is a life member of FOXY, NOGS, AMS, and AMWN. She is an executive committee member and life member of Indian Menopause Society, Nagpur. She is a master trainer at HBB study conducted by Global Network for Women's and Children's Health Research and US National Institute of Health. Her academic achievements are: she has won Best Paper Award at National Conference of IMS Con 2016. Dr. Khandawala Best Paper Award 2016. She has been faculty in various national conferences. She has presented and published many papers in national and international conferences. We welcome you, ma'am.
Thank you very much. Thank you. Good afternoon.
Good afternoon.
Share your screen and unmute yourself. Dr. Neha?
Yes.
Please share your screen and unmute yourself.
Good afternoon, everyone. I'm Dr. Neha Kamble, junior resident at IGGMC Mayo Hospital, Nagpur. Today, my presentation is pregnancy with previous LACS. So I'll start with my case.
Neha, make it full screen.
Yes, ma'am. My patient is a 29-year-old Mrs. Nikita Akash Mahote. She is Hindu by religion, residing at Ramnagar, Pandharpuri, Nagpur. She is 12th pass and is a homemaker. She is belonging socioeconomically to the upper middle class according to the modified Kupuswamy scale. She is a registered case at IGGMC Hospital, Nagpur. She is admitted in labor room on 10th of February 2022 at 6 a.m. with the chief complaint of pain in abdomen since a day. There is no history of leaking or bleeding per vagina. History of presenting complaint: patient has history of amenorrhea of 9 months. Patient had a low backache and intermittent pain in abdomen since a day, which was progressively increasing severity and intensity. Obstetric history: she's married since 8 years, gravida 3, para 2, living 2, is a non-consanguineous marriage. The first pregnancy she has spontaneously conceived after 2 years of marriage. Is full-term LACS is done in view of fetal distress, is an emergency section which is done in latent labor at IGGMC. Baby weight was 3 kg, alive and well. There is no history of NICU admission. Baby is immunized till date. Patient is discharged on 5th post-operative day. There is no history of fever, wound from suture site, or history of bruising, or no history of blood transfusion. The second pregnancy, it is a female baby of 3 years, which is delivered at IGGMC Nagpur, which was a spontaneous normal vaginal delivery at 38 weeks. Baby weight was 2.5 kg, alive and well. Baby immunized till date. There is no history of blood transfusion. There is history of use of barrier method of contraception for a period of 2.5 years after that. History of present pregnancy. My patient has conceived spontaneously after a period of 2.5 years of after her second delivery. First trimester, the urine pregnancy test was done at home by in the second month of missed period. She visited our hospital in antenatal clinic. The antenatal investigations were advised and USG was done. Ultrasonography were suggestive of a single live intrauterine gestation of 7 weeks. She received folic acid supplementation. There is no history of excessive vomiting, no history of urinary complaint or fever, no history of bleeding per vaginum, no history of radiation exposure or drug intake. Second trimester, quickening was felt at 5th month. She received 2 doses of injection DT 1 month apart. She received iron, folic acid and calcium supplementation. Anomaly scan was done at 18 weeks, which was within normal limits. There is no history of fever, UTI, swelling of feet or bleeding per vagina. OGCT was done, which was within normal limit. Patient expresses her willingness for normal delivery in this pregnancy. Risk benefit for the vaginal delivery and counseling of the patient and relatives has been done. In the third trimester, she perceived fetal movements well. There is no history of pain in abdomen, leaking or bleeding per vagina. There is no history of swelling of edema of feet or raised BP reading. There is no history of nausea, vomiting, headache, blurring of vision or epigastric pain. The OGCT is repeated at 32 weeks, which is normal. USG done at 34 weeks, suggestive of normal growth and placenta located in upper segment. The decision for trial of labor reviewed and advantages of the vaginal delivery and the risks are explained associated with the failed trial of labor and explained about the emergency repeat cesarean section. Patient consent for the trial of labor has been recorded. Menstrual history, menarche at the age of 13 years. Her LMP was 11th of May 2021. Expected date of delivery was 18th of February 2022. Her past menstrual cycles were normal and regular. There is no history of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, thyroid disorder, sickle cell anemia. There is no any history of other uterine surgeries or hysteroscopy. There is no history of blood transfusion, drug allergy. Family history is not relevant. Personal history, she consumes a vegetarian diet. There is sleep adequate, bowel bladder habits are normal, no addiction. On recalling diet of last 24 hours, the total calorie required was 2800 kilocalorie, consumed 1900 kilocalorie. There is a deficit of 900 calories. Total protein requirement was 45 gram, consumed 35 gram, deficit was 10 gram. On general examination, my patient was conscious, cooperative, oriented to time, place, and person, moderate blood. The first trimester weight 55 kg, height is 160 centimeters. So pre-pregnancy BMI was 21.5. The total weight gain during pregnancy was around 10 kg. General condition is fair, afebrile, pulse is 88 per minute, regular good volume, blood pressure 110 by 80, mercury meter of Hg, pallor present. There is no edema, fit, lymphadenopathy, icterus, cyanosis, clubbing, no thyroid enlargement, bilateral breast normal. On systemic examination, the serious eyes are normal. On abdomen examination, on inspection, abdomen was longitudinally ovoid, no abdominal wall edema, umbilicus is everted, linea nigra stria gravidarum seen, lower transverse scar of previous lower segment Caesarean section present in the suprapubic area, which is of 10 centimeter in length. Wound is healthy. There is no evidence of keloid or hypertrophy, no dilated veins over abdomen. On palpation, fundal head is corresponding to the term pregnancy. The first grip tell you the soft and broad part, which is a podalic one. The second grip, the lateral grip, back was felt. Third grip, the cephalic presentation by the third grip, and the fourth grip, head was engaged as assessed by the fourth grip. LICO was clinically adequate. Fetal heart sounds are heard at 140 beats per minute, regular heard on the left spinoumbilical line. Contractions present, 2 contraction lasting for 30 seconds in 10 minutes, relaxing in between. There is no scar tenderness. On per vaginum examination, the cervix is 3 centimeter dilated, 40 to 50% effaced, membranes present, station -2, pelvis is adequate, modified Bishop score is 8. So my diagnosis is 29-year-old, gravida 3 para 2 living 2, previous 1 LACS followed by 1 VBAC at 39 weeks of gestation with single fetus in longitudinal like cephalic presentation, left occipito anterior with good fetal heart in latent phase of labor. Thank you.
Now will you proceed with the management of the patient, and you just tell me whether you have covered everything in your history taking, history of present illness. You said that she had pain in abdomen.
Yes, ma'am.
Anything else you want to ask? Will you like, please elaborate the history of present illness again to us?
Ma'am, she had a low backache and intermittent pain in abdomen since a day, which was progressively increasing in pain and severity. But she does not give history of her stitch site pain or a sudden gush of blood from her vagina and bleeding. She's just giving a pain in abdomen, which is from back and radiating to the abdomen.
Any other thing that we confirm whether she is having true labor pains or not by
the labor pain were not relieved by rest, and they are gradually increasing with the severity and intensity.
Apart from bleeding, any discharge will you like to ask? Any show, any water discharge, anything else that will tell you that yes, she must be having true labor pains. Isn't it associated with show? So that completes your history of present illness.
Okay, ma'am. Yes, ma'am.
Okay. Yes, ma'am. Now proceed with your management, as she is a case of previous 1 C-section followed by VBAC.
Yes, ma'am. When the patient has come to the labor room, first the vitals are checked. Her history was reviewed once again on the ANC papers, for where she has the willingness of VBAC was there, a consent of trial of labor for willingness is there, a consent was there. So again, the risks are explained to her as she is in now a latent phase of labor. Then I want to check for the fetal heart sounds.
You have done that. I am asking you now, what else you will like to do?
Ma'am, after informed consent, I will like to keep the patient in labor room for monitoring for the spontaneous onset, spontaneous delivery of the labor, as she is willing for a vaginal delivery.
Yes, that's true. Will you like to review her investigations? Will you like to confirm something?
It is admission.
Ma'am, investigations, basic investigations of the routine investigations. I'll check for the blood group. I'll see to it what is the HB. I'll see to it that the blood is to be reserved, the cross match to be reserved at my blood bank. Yes, even if
previous C-section is in labor,
yes,
you have to check for the availability of compatible blood, right?
Yes, ma'am.
Now answer what Surekha madam is asking you.
Yes, ma'am.
What are the criteria for a vaginal birth after cesarean?
Yes.
How will you decide whether the patient is eligible for vaginal birth after cesarean or not?
Yes, ma'am. The pelvis should be adequate. There should be no other obstetric complications such as preeclampsia. She should come in a there should be a consent for her willingness for the vaginal delivery. There should not, with the previous ANC records, I'll check whether the previous scar was which type of scar. It was a lower segment scar or a classical one. If it is a classical one, I won't go for a VBAC. If it is a lower transverse scar, the integrity of that scar is a sound one. So the lower transverse scar, I'll check for it. Where the previous section has been done, at which hospital, what was the indication for that section. How is the scar now? It is a good healthy scar with healed by primary intention or not. So these are all
by good healed scar. And how the scar heals? What is the physiology of scar healing? Elaborate.
Ma'am, if coming to a uterine scar, the uterine scar heals by complete smooth muscle regeneration. If it is with the proper hemostasis, it will heal, the fibrous tissue will get proliferate fibroblast formation, then the smooth muscle will come in between, and there is a complete regeneration by smooth muscle regeneration. So that is a sound and good scar. When it comes to not sound scar, that means if there is improper hemostasis, or if there is not a proper approximation, or if there is a blood clot, then the in between the smooth muscle there is inclusion of the fibrous tissue, and the scar will be weak and it won't be sound.
Are there any tests to find out whether this scar is good scar or a scar which may give in labor, in between pregnancies and during pregnancy?
During pregnancy.
Are they recommended?
Ma'am, by ultrasonography, yes, we can check for the scar thickness. The scar thickness bit more than 3.5 mm to more than 4.5 mm is considered as a good one. To 3.5 mm to 4.5 mm is good. Anything less than the scar thickness less than 2.5 mm is considered to be a risk for the rupture. So yes, ma'am, by ultrasonography we can check.
What are the recent guidelines? Do they include scar thickness before deciding whether the patient is for TOLAC or not?
Ma'am, no, actually, because either a good scar even can rupture, so it is not it won't be on completely dependent upon the scar thickness, so it is not included.
Will you proceed with her management of labor now?
Yes, ma'am. Ma'am, in her, I'll ask her to empty her bladder. I want to check for her scar tenderness. I'll check her BP pulse. I'll check the maternal pulse.
How do you check for this scar tenderness?
Yes, I'll ask my patient to empty the bladder. A patient in supine position. I'll see to it that the contractions are not there, because the contraction may give a false impression. I'll take my one hand on her maternal pulse, and with the right hand palmar aspect, I'll try palpating from right hypochondriac region to the other. And it should be a deep palpation, and I'll see to a response on her face. If she winces with the pain, it is a sign of a scar tenderness. And the most consistent sign will be with the cardio topography machine. I'll see for the fetal heart rate variability. A sudden fetal heart tachycardia followed by bradycardia is a consistent sign of a scar.
But where do you palpate, Neha, actually? I want that site. Where do you palpate? Where is the lower uterine segment anatomically? Is it abdominal or is it pelvic?
It's pelvic, ma'am.
So how do you palpate? You said hypochondriac, right?
No, from the lower, from the right.
Yeah.
From the right supra, just above the pubic hair line, from one end to the other.
Usually try to insinuate the fingers just below the symphysis pubis, and then palpate gently and just look at the expressions of the mother. That is how we see for this scar tenderness, right?
Yes, ma'am.
What are the factors, Dr. Neha?
Yes,
what are
ma'am.
the factors that are favoring VBAC in your case against repeated previous cesarean section?
Yes, ma'am. My patient has come in a spontaneous labor, which is with the modified Bishop score of 8. It is one of the good factor. She has a history of one VBAC, so that my scar was already tested for once for the VBAC. There is no any other obstetric complication to the patient like preeclampsia. Her investigations are normal, so there is no. She is not in high risk ANC. And ma'am, she is willing. Yes, she is not a high risk. She is not a high risk spontaneous labor pain with one vaginal delivery have a VBAC success rate of almost 85 to 90%. Yes.
Yes. And So what is a VBAC score?
Yes, ma'am. We have Weinstein score for to evaluate the predict the success rate of VBAC. In that Weinstein score, we have parameters: previous vaginal, if there is previous vaginal delivery, what is the previous section was done is grade as A, B, C, D, and what is the modified Bishop score? With modified Bishop score, if it is more than equal to 4, it is termed as 4, and then ma'am, there are like more than equal to 4 have a success rate of 68. A score of more than equal to 12 will have a success rate of 70 to 80%.
Then what is the first sign of impending scar rupture while you are monitoring a case of this VBAC? And what is the first sign that you will get of impending scar rupture?
Sudden drop in a fetal heart rate, sudden bradycardia will be the first.
Impending rupture, tachycardia, usually.
Bradycardia is the most consistent sign.
Yes, ma'am.
What next? That is the first sign, but what are the other signs by which we become alert and we are prepared to proceed? That is the first sign.
Yes, ma'am. Ma'am, we'll do a per abdomen examination, the palpation.
Are there any complaints put up by the patient which can raise an alarm?
Ma'am, first there was intense pain, which is followed by sudden stoppage of the pain.
I'm not talking about scar rupture. I'm talking about impending
scar rupture.
Impending. Okay. Ma'am, severe lower abdomen pain followed by and on per vaginum examination there will be slight amount of bleeding will be present.
It is just spotting.
Spot, yes.
Is she able to empty her bladder completely?
No, ma'am, there will be a feeling of incomplete evacuation of the bladder in case of dehiscence. Yes,
what is the difference between scar dehiscence and scar rupture?
Ma'am, in scar dehiscence, there is there is loss of the uterine scar along the length, but there is still the membranes are intact and the peritoneum is intact in scar dehiscence. In scar rupture, along with the visceral peritoneum and the membranes will be rupture and the fetal part will come outside the incision. So that is scar rupture.
As your patient is already 3 centimeter dilated and 50% effaced, she is getting 2 contractions in 10 minutes. How will you further monitor her progress? And if the contractions don't improve, will you like to do something else?
Yes, ma'am, there are 2. I will first watch for increase in the uterine contraction. I'll first only start with a plain RL drip and just see for the uterine contractions are increasing or not. If they are not, there are guidelines. We can augment it with oxytocin, but with a very careful and watchful expectancy. We have to give oxytocin. So I will give oxytocin, but with a very proper augmentation.
Any other simple measure you can do to augment the labor?
I'll do ARM, ma'am, amniotic rupture of the membrane, so that
the rupture of the membrane. That will tell you about the color of the liquor.
Color of the liquor, and so the decision can be made.
Then augment the labor.
Can we use prostaglandins for induction of labor in previous cesarean section?
Ma'am, prostaglandins such as misoprostol tablet is contraindicated as they are more too prone to the rupture of the uterus. So we are not recommending misoprost or dinoprostons. So that is contraindicated. They are not using it.
How to manage a second stage of labor then?
Ma'am, when my patient when she's now almost 7-8 centimeter dilated, we can cut short the second stage of labor by the use of forceps or a ventouse, so that should be an easy delivery.
7-8 centimeter is
How
which?
No, I'll wait for to be fully dilated.
Full dilatation.
Full dilated.
And after full dilatation, for how much time you will get?
Ma'am, as
which phase of second stage you will think of applying the forceps to cut short the second stage?
the head station at +1.
+1?
No, no. What are the criteria for forceps application?
The read it, ma'am.
Prerequisites. What are the prerequisites?
Prerequisites for forceps application. Ma'am, the patient should be fully dilated, fully effaced. The head
station.
The head station should be at least +1 to +2 for the proper application of the forceps.
Okay, what is the Robson's classification?
Yes, ma'am. Ma'am, Robson's classification, it is for the standardized data. There are the parameters from which we can classify it into the 10 groups. The parameters are the gestational age of the patient, the parity, if there is any previous Caesarean history, if there are what are the onset of the labor pain. So we have in this we have the 10 groups. In the first one, it is a term pregnancy more than 37 weeks.
What is the basic idea behind this Robson's classification?
Yes, ma'am. We can from in the 10 groups we have the different women which are coming to our labor room for a delivery. It might be a vaginal or a section. So as we are grouped in them in 10 groups, we can see that which group is trending towards the more Caesarean rates, or which group is likely to have a more Caesarean rates. So it is for the standardized data.
Standardization of the data all over. That is why the Robson's classification is there. Yes. Because the primary Caesarean section rate is on a rise.
Rising.
How much is the expected Caesarean section rate? That is ideal for any institute.
It should not go beyond 15%.
And what do you think? What are the conditions which are contributing to increase in primary Caesarean section rate?
Ma'am, over-diagnosing of fetal distress because of continuous use of cardiotopography monitoring. The obstetricians are also highly monitoring the labor at each and every point of time.
That are not the leading causes? That cannot be? Yes, advent of the gadgets, we pick up the things early, but what are the other main factors? Some socio-demographic factors which are also contributing?
Ma'am, Caesarean delivery and maternal request.
That is one thing. Age of marriage?
Yes.
Plans for pregnancy becoming late? More
pregnancy
of ART, breaches are not given trial. No, very few obstetricians are having a good training in delivering breaches. So they are all taken for Caesarean section. That is the main thing, that more number of Caesarean section are done primarily. And then once the C-section, most of the institute follow a repeat C-section.
Repeat C-section.
What is the difference between lower segment Caesarean section and classical Caesarean section?
Ma'am, a lower segment Caesarean section will have a good hemostatic approximation will be good because the lower segment is thin. The margins can be properly sutured. The post-operatively, the patient can have a benefit. The scar rupture rate will be less in a lower segment scar, while that of the classical scar, there is more bleeding. It is a thickened one, so more bleeding. The approximation of the edges can't that be proper. That is why the rate of scar rupture in the subsequent pregnancy is more.
So what are the indications of classical caesarean section?
Classical when the lower uterine segment, in case of a when the lower uterine segment can't be approachable, in case of there is the bladder advanced, we turn it to a classical caesarean section. Placenta previa, adherent placentas will switch on to the classical caesarean section. Malpresentation in which we are not able to extract.
Okay, after you have delivered your patient, is there a role of routinely exploring the scar on the uterus?
Studies have said that there is no need for a routine exploration, because you might routinely exploring, you might just put something more dangerous, like if a scar dehiscence is there, it may have heal spontaneously. So it is better not to do on a regular basis. If the patient has certain amount of complaint, then only the exploration should be done.
Okay, during labor, if she ends in rupture, how do you identify it?
Rupture. Okay. Yes. Ma'am, on my topography machine, I can see a sudden bradycardia. The patient clinically will be having attack.
Suppose a patient has a fetus which has gone already for intrauterine demise. She is a case of previous C-section and she is in labor, given a TOLAC. How will you identify that she has gone in for rupture?
Ma'am, I'll catheterize the patient and we'll see for the
First, tell us what are the symptoms and what are the signs by which you will diagnose.
Ma'am, the patient will, the excruciating pain will now be followed by a sudden cessation of pain. There is something, sensation of feeling of something giving away. On per vaginum examination, there will be loss of station, loss of presenting part, and bleeding will be present. And ma'am, on catheterization, we can see the, sometimes you can see even the hematuria is present.
What happens to uterine contour?
Yes, ma'am, the uterine contour will lose. We can feel the fetal parts on the abdomen.
What is loss of station?
Ma'am, if she is, suppose the station is at 0, because of the baby will go into the abdominal cavity, the from 0 to, she will just go it to like -2.
What about the general examination findings?
Ma'am, on general examination, there will be tachycardia, maternal tachycardia, hypotension. Patient, if a patient may land up, there can be a signs of shock.
How will you manage the patient?
Ma'am, first I'll arrange blood and blood products for my patient. I'll immediately inform my OT, my senior consultants, and will shift the patient to OT for the exploration.
Sorry to interrupt you, but we are running short of time.
It's okay. We can conclude here.
Yeah, yes, ma'am.
And I will recommend that, Neha, you need revision and basics to be told first, and then come to a local examination findings. First, you should go ahead with general examination findings. Surekha, you can contribute.
Yes.
Thank you, Dr. Neha Kamble, for nice case presentation. Thank you, Dr. Alka Patankar ma'am, Dr. Surekha Khandale ma'am and Dr. Mugda Zungari ma'am for your precious time and for judging this session and sharing this useful information. Thank you so much, ma'am.
Thank you. Thank
Thank
you.
you very much.
Thank you so
Thank
much.
you, Neha. Thank you, ma'am.
Thank you so much.
Thank you.
Thank you.
Female MC. Thank you very much.
RPL is seen in 1 in 300 pregnancy and affect 1 to 2% of women. Hence, understanding the etiology, appropriate diagnostic evaluation and treatment is required. So our next case presentation is on recurrent pregnancy loss by Dr. Amruta Kharode, and she's from JNMC Savangi. And our faculty judges are Dr. Shama Kedar ma'am, Dr. Anuja Bhalera ma'am, and Dr. Prachi Dikshit ma'am.
Dr. Shama Kedar ma'am. She is Associate Professor and Unit Head of OBGYN Department, IGMC Nagpur. She is a postgraduate teacher since 25 years. She is a national faculty for HIV and RTI, STI. She is a national faculty for CAC, IPAS. She has been faculty for medical education, technology, and research methodology for many years. We welcome you, ma'am. Then our next faculty is Dr. Anuja Bhalera, ma'am. We welcome you, ma'am. Our next faculty is Dr. Prachi Dikshit, ma'am. She is Associate Professor in Department of OBGYN, NKP, SIMS, and LMH Nagpur. She has done her MS OBGYN from the renowned institute Lady Hardinge Medical College, and she is a receiver of Dr. Pushpa Madan Medal as a Best All-Rounder Postgraduate Student of the Year 2011. She is a member of Task Force Maharashtra University of Health Sciences for implementation of CBME. She has been awarded Best Poster and Paper Presentation in national conferences. She has authored chapters like Approach to Pregnant Women Presenting with Convulsions, Clinical Methods in Obstetrics and Gynecology by Dr. Manju Puri. She has also authored a chapter, Fetal Dysmorphology. She is passionate about quality improvement in medical education and research. We welcome you, ma'am.
Dr. Amruta Kharode, are you there? Please share your screen and unmute
Yes, ma'am.
yourself.
Yes, ma'am.
First of all, I thank
Can you hear me,
all
ma'am?
the organizers. Till the time she starts, I just want to thank the organizer for having me in this such an important session. Can you hear me?
Always welcome.
At the last moment.
No, ma'am. You're always welcome and instrumental in running of this program, the success of this program. It all depends on our shoulders combined.
चलो यार जल्दी जल्दी दो है back to back.
Yeah.
Amruta?
Yes, ma'am.
Start presenting your case.
Yes, good afternoon, ma'am. My today's topic is recurrent pregnancy loss. Myself is Dr. Amruta Kharode from JNMC Savangi, Varda. I'm presenting a case of Sushma Ashish Devkar, age 31-year-old, gravida 4, abortion 3, housewife by occupation, wife of Ashish Devkar. She is 32 years old, engineer by occupation, residing at Devli, Varda, Hindu by religion, belonging to upper class, came to OPD for the checkup. On examination, we found that her BP was raised, so she was admitted for monitoring and further management. History of present pregnancy. She came in OPD with 8 months of amenorrhea. She was admitted in view of hypertension. There is no complaint of headache, vomiting, blurring of vision, epigastric pain. No complaint of pain in abdomen. No history of any bleeding or leaking PV. Patient was perceiving fetal movement well. History of present pregnancy. First trimester. Pregnancy was first diagnosed in 2nd month of gestation at private hospital and registered there. It was a spontaneous conception. There is no history of any urinary complaints. First ultrasound was done at 2nd month of pregnancy. Anti-scan was done at 11 weeks, which was normal. Patient was started on tablet aspirin, 75 mg OD, and injection enoxaparin. She has taken tablet folic acid from 1st month of pregnancy. 2nd trimester. She received 2 doses of injection TT. Anomaly scan was done at 20 weeks, which was normal. Quickening was felt at 4th month of the pregnancy. GTT was done at 24 weeks of gestation, which was normal. Thyroid profile was done, which was within normal limit. Iron and calcium tablets were taken. 3rd trimester, patient was diagnosed with hypertension in 8 months of pregnancy and started on antihypertensive after admission. Patient perceives the fetal movement well. Obstetric history. Age of marriage was 8 years. It was non-consanguineous marriage. She was gravida 4, abortion 3. First abortion was 5 years back. It was a spontaneous conception. Urine pregnancy test was positive. First trimester scan shows fetal cardiac activity. Then she started bleeding. There is no history of any suction or evacuation. In second trimester, it was 3 years back. It was also a spontaneous conception. Scan was done, which shows missed abortion. Suction or evacuation was done at that time. Then at the time of third abortion, it was 1.5 years back. It was spontaneous conception. Urine pregnancy test was done at home, which was positive. First trimester scan shows fetal cardiac activity. She started bleeding spontaneously at home. At that time, the product of conception were sent for further histopath report and karyotyping, which shows no abnormality. There is no history of hypothyroidism, diabetes mellitus. There is no history of fever or blood transfusion in post-abortive period. Now she is with present pregnancy. Menstrual history. Regular 28 days cycle with average flow for 3 to 4 days. There is no history of dysmenorrhea, any clots, or her 21st of July 24-22. Period of gestation is now 32 weeks, 3 days. Past history, there is no history of diabetes mellitus, hypertension, thyroid disorder, tuberculosis, asthma. No history of any thromboembolic episode in the past. No history of taking long-term medication. No history of any surgery in the past. Family history. Father is hypertensive. There is no history of diabetes mellitus, tuberculosis, congenital anomaly in the family. There is no history of also thromboembolic episodes in the family. Personal history. Consumes milk diet, normal bowel and bladder habit. There is no history of smoking, drug abuse, or alcohol consumption. General examination. Patient is conscious, cooperative, well-oriented with time, place, and person. Her pre-pregnancy BMI was 23. Pulse was 88 per minute, regular, good in volume, bilateral synchronous. Peripheral pulses were palpable. Respiratory rate was 16 per minute. BP was 130 by 80 mm for Hg taken in supine position. Pallor was absent. Bilateral pedal edema was present. Breasts were normal. Thyroid and spine were normal. Systemic examination. Cardiovascular examination shows S1, S2 heard normally. There is no murmur. Respiratory system. Air entry was bilaterally equal. No adventitious sounds heard. On obstetric examination, on inspection, abdomen is uniformly enlarged. There is linea nigra and strigavidarum were present. No scar marks and no dilated veins. On palpation, per abdomen, uterine height is 30 to 32 week size. Relaxed. It was single fetus, longitudinal lie. Cephalic presentation. Back was felt on right side. Floating. FHS was heard 144 beats per minute in right spino-umbilical line. Symphysiofundal height was 32, which was corresponding to the gestational age. Abdominal girth was 80 centimeter. Per vaginal examination was not done. Diagnosis is 31-year-old, gravida 4, abortion 3, with 32 weeks of gestational age, with following two high risk factors. One is recurrent pregnancy loss, second is gestational hypertension.
PS done for her?
Yes, ma'am.
Per speculum examination was done for her?
No, ma'am.
What is the importance of doing a per speculum examination in a patient with RPL?
We can see, ma'am, by per specular examination, we can see any abnormality like white discharge or any mucopurulent discharge or cervical consistency like cervix is open or it is closed, cervix is short cervix, So there can be chances of preterm labor pain.
Okay.
And infection leads to recurrent pregnancy loss.
You tell me one thing. How will you define recurrent pregnancy loss? You are saying recurrent RPL. How will you define it?
Yes, ma'am. There are more than 3 or more pregnancy loss, less than 20 weeks of gestational, which is clinically viable, clinically demonstrable, or clinically registered. Like scan is there or the UPT is positive, but it should be less than 20 weeks of gestation.
And what is primary RPL?
But according to
yes,
according to recent guidelines, ma'am, ASHRAE classification, ASHRAE guidelines said that it should be less than 2 or more recurrent pregnancy losses, then it is called as recurrent pregnancy loss.
Okay, what is primary recurrent miscarriage and what is secondary? How will you differentiate? Whom will you label primary and whom will you label secondary recurrent miscarriage?
Primary pregnancy loss is without previous viable fetus, and the secondary pregnancy loss is associated with prior pregnancy. Then she had recurrent pregnancy loss.
And what about the incidence of RPL?
It is 1%, ma'am, in all the fertile women.
Like what are the risk factors for this recurrent pregnancy loss?
Ma'am, can I interrupt? Like you said, the incidence is 1%. Will it depend upon the definition of recurrent pregnancy loss? Like lately, the definition has changed to 2 recurrent pregnancy loss. Initially, it was 3 consecutive pregnancy losses. So will the incidence change? Is it still 1%?
Yes, ma'am.
Yeah.
So is it still 1%?
If there is no, ma'am. If there is one previous pregnancy loss, then the chances of pregnancy loss in this pregnancy is 10%, 10 to 14%. If there is 2 pregnancy loss, then chances of pregnancy loss in third pregnancy is 20%, 20 to 30%. If 3 pregnancy loss, then it is 30 to 40%.
No, this is not what I wanted to ask. You defined the recurrent pregnancy loss as 2 consecutive losses, right? The latest guidelines say that 2 consecutive losses or 3 losses. Yes. What do you say?
Yes.
So the incidence was 1% when we defined it as 3 consecutive losses. Now, when the definition has changed, the incidence will also change. Yes. So what is the current incidence?
Yes, ma'am. According to ASHRAE guidelines, it is 0.8 to 1% now.
Okay. I want to say that if the number increase, if you decrease the number of consecutive losses, that is 2, then the incidence rises to about 5 to 7%. That's why whenever we define something or bring up with guidelines which are defining something, we have to be very thoughtful about it, because now you plan to intervene at 2 consecutive pregnancy losses and the incidence is as high as 5%. Okay. Yes, please proceed. Ma'am, you were asking something.
See, and always just 1 minute. See, and always understand when RCOG is saying it as more than 3, they are also including the biochemical losses.
Yeah, exactly.
Which are not being considered so many
Yes,
times by history or ARN. ASR. Yeah. Okay. So let's move ahead.
So what are the risk factors for this RPL?
Risk factors, ma'am, in women who are elderly gravida, like age is more than 35 years.
Okay.
Hello.
Yes.
Am I audible? Yes. If she is known case of diabetes mellitus, then she has any chronic PID or chronic endometritis, then pregnant patient having any uterine anomaly or the cervical congenital anomalies, then a patient having if she is having poor ovarian reserve, there are more chances of chromosomal abnormality in such a female.
So you
and in paternal also, ma'am, if the father is more than 40 years old, there are more chances of chromosomal abnormality.
Okay. If you say causes of this miscarriages, you have enumerated genetic as well as some endocrinal too. So what
Yes, ma'am.
genetic causes you would like to say?
Ma'am, uterine anomalies like uterine septum.
Genetic causes I am talking of.
Oh, sorry, ma'am. Genetic causes like fetal aneuploidy, chromosomal abnormality, chromosomal translocation such as Robertsonian translocation between 13 to 15, in which that are more common are unbalanced chromosomal translocation. And it leads to 5 to 10% chances of recurrent pregnancy loss in a woman.
Okay. And how do this parental balance translocation lead to miscarriage? You're saying you were saying something like this?
Yes, ma'am. Robertsonian translocation, in which one arm of the chromosome is detached and attached to the other chromosome, so that the embryo which is formed, it is not proper for the implantation, and the uterus, that is endometrium, rejects the embryo for the implantation. So
Is it
unbalanced
only the
translocation are.
translocations that matter, or there are other genetic compositions which can also lead to an RPL?
Ma'am, other genetic composition are also there, like trisomies, chromosome trisomy 21, trisomy 18, trisomy 13, like Patau
So
syndrome.
basically
It can
mosaicism
lead to,
inversion.
yes, mosaicism inversion, and yes, ma'am.
What is mosaicism? See, whenever you have a case of RPL, it is very important for you to know what is the difference between a mosaicism and a chimerism. Okay? Can you just give me an example of any mosaic that you know
Sorry, ma'am.
of? Okay, we'll move ahead.
Okay. Do you really go for the karyotyping routinely in this pregnancy loss?
Ma'am, karyotyping.
What are the points for an addition?
Karyotyping is indicated. Sorry, ma'am.
Will you recommend routine karyotyping in such patients?
Routine karyotyping is not recommended, ma'am. If there are more than 2 pregnancy lost, then we do karyotyping of the products of conception. But in that case, if the products of conception shows any karyotyping, then the paternal karyotyping is indicated. Like mother or father karyotyping is indicated.
Which is better, paternal, parents karyotyping or the fetal karyotyping?
Yes.
If you have given
fetal
karyotype, fetal
if,
tissue
products
karyotype.
of yes, ma'am. Fetal tissues are sent for karyotyping. If the karyotyping is abnormal, then there is chance of if the karyotyping is normal, then chance of second pregnancy viability is more. If the products of conception show abnormal karyotyping, then we do paternal
The chances
and
of having
maternal.
a successful pregnancy is better in the next
Yes.
That will depend upon the type
If
of
it is
aneuploidy
normal.
you get, right? And then intervention will
Yes.
also depend upon that. What report are you getting?
Yes, ma'am.
So what testing will you offer? You will have to write on the investigation slip, right? Get this test to be done. Which test will you like to do? For the fetal tissue, you're sending the fetal tissue for karyotyping. So what test do you advise? Conventional karyotyping, what test? Yes.
Ma'am, in that show, there are some tests like G-band karyotyping or CGH microarray testing.
Okay.
CGH microarray testing
you
is
preferred
better,
it
ma'am,
over fish
because
testing. You preferred it over fish testing, right?
ma'am, G-band karyotyping.
Yes. What is the CGH microarray testing?
Ma'am, in CGH microarray testing, there is no need of viable tissue, and there is no chance of maternal contamination. So it is better than the other karyotype.
Something which is better than CGH, because here in this CGH method, again, there is a chance that you may miss some mosaic patterns. So can you have something better than CGH, which can detect even the single gene, all area of single gene polymorphisms, etc.? Which is the best if you have everything available, adding to the recent guidelines. So something which is called next generation sequencing. The advantage of next generation sequencing is a non-viable fetal tissue, no maternal mixing of the tissue, as well as single gene defects, because it screens whole of the genetic makeup of the tissue. So this one is something which will add to. In your patient, will you like to do, like now your patient is already pregnant, okay, and we're talking a lot about genetic defects. Suppose there was some genetic defect, your patient does not have one, of course she is now having a 8-month pregnancy. What could you offer if the reports come positive in any other patient? What are the various offerings that you can give for next pregnancy?
Ma'am, if the products of conception karyotyping shows abnormality, then we give the option like pre-genetic screening. Like we give her the option of IVF, which can be a better option. So pre-genetic screening, in which the screening of the embryo before implantation is done, and if the embryo shows abnormality, then we discard that embryo, and which is the good embryo which we transplant into the mother uterine cavity. To the
Amrita, you
mother's
said pre-genetic screening. What
Yes,
is the
ma'am.
difference between pre-genetic screening and pre-genetic diagnosis?
Ma'am, in pre-genetic screening, we screen the embryos before transferring into the uterine cavity in IVF. If the embryo shows abnormality, then we don't transfer that embryo. And in pre-genetic diagnosis, if the maternal and if the mother and father is positive for some abnormality, like genetic abnormality, we screen.
Translocation.
Yes, ma'am. In we search for the particular disease in that embryo.
Yes, pre-implantation.
Yes,
Genetic
pre-implantation
diagnosis.
diagnosis.
Okay. So what are the options that you are going to give? That is Dr. Prachi's question for you. If there are chromosomal aberrations in the baby and some abnormalities have been found.
Yes.
So what are the options you are going to give to the couple? And then we move to the next cause.
Ma'am, if there we can give option like pre-genetic screening we can done, and the healthy embryos which are healthy we can transfer through IVF, or we can
Okay.
give the option of donor embryo.
Yeah, gamete donation.
Yes, ma'am.
Or what else? You can tell them to go in for adoption.
Yes, ma'am. Adoption is the
So
best.
these are the options that you can give, or they can have a natural conception, and without doing amniocentesis or CVS, the pregnancy can continue like
Yes,
that.
ma'am. Yes, ma'am.
Okay. Okay. So whenever we have a patient of recurrent pregnancy loss, what is one of the important causes that has been found for RPL?
Ma'am, important causes we have to rule out like endocrine causes, anatomical causes, then any infectious causes, immunological causes are there. In endocrine causes, we have to rule out like diabetes mellitus, luteal phase defects, then insulin resistant, increased level of LH, poor ovarian reserve is the main cause. Then
Most important, along with TSH, what other investigation you would like to do?
Along with TSH, anti-DPO antibody.
So that is very important because they are the ones which are responsible for
Yes.
recurrent miscarriage.
Yes, ma'am.
Okay.
And
So
how
what
will you
is
like to screen? Yeah, how will you like to screen the sugar? You said that you will test for diabetes mellitus. Which test will you do for diabetes mellitus?
Ma'am, we will do if she is pregnant, then in pregnancy we can do like OGTT test. If she is not pregnant, then HbA1c is the best test for the diagnosis, and along with that, fasting and post-meal sugars we can do.
HbA1c is the best test. Amrita, what you found your patient with 2 months of pregnancy. What is the right time to do all these investigations? What is the correct time to get the
OGTT
patient?
is, ma'am, in OGTT we can do 24 to 28 weeks in between.
No. I am saying that what is the correct time for a patient to get investigated in a case of recurrent pregnancy loss? Like there are
At
so
that,
many investigations.
as soon as she came in our OPD, ma'am.
Can you test for, you started her on low dose aspirin and low molecular weight heparin, right? Did you have any basis for starting this management? Did you investigate her for that?
Ma'am, we haven't done like any antibodies for APLA or any thrombophilia, but it should be done because in APLA, like if we found anticardiolipin antibody, beta-2 glycoprotein or lupus anticoagulant antibody, then the aspirin and low molecular heparin increases the chances of pregnancy and continuation of the pregnancy, and the risk happens in a latter part of the pregnancy.
So that's what I'm
Amrita,
asking.
just one question.
When will you
If you
like
start,
to test her?
yeah, if
During
you start,
pregnancy, will you test her?
And before, after her viability scan, like
You will
we
test her after viability scan. Antiphospholipid antibodies, you said beta-2 microglobulin, anticardiolipin antibodies. Are these to be tested in pregnancy or in between
ma'am,
pregnancies?
before pregnancy, we should have done
Before
all this
pregnancy.
investigation before pregnancy, and we should start aspirin before she conceives.
what is the drawback of starting aspirin before conception? What will be the effect on the once she conceives? What can go wrong? So that is one of the drawbacks.
If she conceives and she has again miscarriage, then there are more chances of bleeding, excessive
No.
bleeding.
There can be corpus luteal hematoma, which can mimic a patient with like an ectopic. So that is one thing that you always need to keep in mind. Okay.
Is there
So,
shall I?
Yeah,
yes,
ma'am. Is there any role of prophylactic cerclage in this patient? She is the previous 3 abortions.
No.
There is no.
Ma'am, all are first trimester abortion.
Yes. Okay. But every time she
And,
has undergone
cervical
dilatation and curettage, isn't it?
Yes, ma'am. In one pregnancy, we have done suction evacuation, but cervical insufficiency leads to second trimester abortion most commonly.
Yes. Yes, most common. Okay. But is there any role such type, or if there is a previous 3 abortions, will you give prophylactically cerclage? Though first trimester.
If we will do the cervical scan by TVS, if the cervical length is less than 2.5, then there is role of doing cervical encerclage. Otherwise, there is no such a proven rule, ma'am.
Amrita, you said that these are first trimester for very early pregnancy losses. So were they embryonic or were they anembryonic? Is it important for us to know that?
Yes, ma'am.
Does your management differ if you know whether they were embryonic or whether they were anembryonic? Do you get a clue as to what can be the cause of it?
Ma'am, if there are anembryonic, there are more chances of chromosomal abnormalities.
Very good. And if they're embryonic and there is a loss of fetal heart, what does that tell you?
Ma'am, then there may be it suggests that there is no proper implantation. So there can be APLA or thrombophilia.
Yeah, very good. So if there has been presence of fetal heart and it means there is loss of fetal heart, that tells you that the etiology might be thrombotic. But if it would have been an anembryonic one, it tells you that there has been some problem with the conceptus, right? So our investigative approach changes when you get to know these small things about when we take a history. Okay.
Yes.
So moving on to APLA, Prachi, you want to ask?
Yeah, how, if suppose you got the patient at the right time, that is interval period, then how would you, what were the risk factors which made you decide that you will order antiphospholipid antibody profile for this patient, what antibodies would you specifically order, and how will you interpret the report?
Ma'am, for in case of APLA, we can do anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein antibodies. But most specific antibody is beta-2 glycoprotein IgM antibody, which shows more correlation with recurrent pregnancy losses. So if we do the antibodies screening, then it should be repeated after 12 weeks, and 2 titers should be positive. 2 tests should be
What do you
positive.
mean by positive? What do you mean
What
by positive?
levels?
It is done by ELISA test, ma'am. More than 50.
40 and 45.
Yes, yes.
What is the mechanism of by which there is pregnancy loss with APA, antiphospholipid antibodies?
Ma'am, they act on the endothelium and the platelets. So there is microangiopathy, which lead to improper implantation. So there are more recurrent chances of pregnancy loss.
And most importantly, thrombosis.
Yes, thromboembolic phenomenon.
And the another important thing why we give aspirin is thrombosis and heparin, because there is an inflammatory reaction at the interface between the fetus and the mother because of the stimulation of complements. So that is one. So how do you diagnose this antiphospholipid antibody syndrome?
There are 2 criteria, ma'am. One is clinical and one is laboratorical. In clinical criteria, if there is a previous thromboembolic phenomenon, there are 2 to 3, more than 3 loss of recurrent pregnancy loss, which are less than 10 weeks of gestation. If there is any evidence of any preeclampsia or associated gestational hypertension before 34 weeks of gestation, and there are 2 or more pregnancy loss less than 10 weeks of gestation. Then laboratory criteria. Yes, ma'am.
Even a single loss of greater than 10 weeks of gestation and less than 10 weeks, 2 or 3 losses.
Yes. And in laboratory criteria, as we know, anticardiolipin antibody, lupus anticoagulant antibody, and beta-2 glycoprotein antibody we can do. That should be 12 weeks, twice 12 weeks.
That should be done in 12 period, 12 weeks apart. Okay. If these tests come negative, are there some other immunological causes that can be responsible for similar presentations?
There are unexplained immunological clauses in which TH2 and TH1 mechanism is there. TH1 mechanism, like T helper cell 1 mechanism, is hazardous for bad. It leads to like tissue necrosis factor alpha and interleukin 2, which activates the coagulation cascade, and it is responsible for the abortions. And the T helper cell 2 mechanism, it is the preventing mechanism. And there is one role of progesterone is there, like progesterone progesterone binding factor bodies, which causes the T helper 1 mechanism, and it prevents the pregnancy losses.
So there are so many LO immune mechanisms which are being told, right? Yes. And then there are, so do you recommend testing on those? What do the recommendations say? Should we test all these? We should offer HLA antigens, HLA matching. If there is HLA matching, that leads to abortions and presence of antihistocompatibility antibodies, etc. So do you want to recommend these tests?
No, ma'am.
What do the guidelines
because
say?
This, according to studies, there is no significant association.
Yes, as of now, they are not recommended. Only antiphospholipid antibody, and if you are suspecting secondary autoimmune disorder like SLE, then you can offer anti-nuclear antibodies.
SLE.
Okay. Now there is also a
yes, ma'am.
No, you started aspirin and low molecular weight heparin. That was started empirically. Now, some people also start steroids, low dose prednisone on therapy, and IV immunoglobulins and interlipids. So, can you give me few names and recommendations about those?
If the endometrial biopsy we had done and natural killer cells are positive and CD56 is also positive, then there is role of steroids and IVIG. Up to 12 weeks of pregnancy, we can do 40 milligram subcut twice, 1 to 2 weeks apart. And steroids also can be given up to 12 weeks of pregnancy. Then there is role. But in other cases, there is such no significant role of steroids and IVIG. But some studies says that in association with aspirin, low molecular weight heparin and IVIG, and there are some like tumor necrosis factor alpha antibody like etanercept and adalimumab. Yes, ma'am. Then there are more chances of preserving the pregnancy or association of effective pregnancy. 70 to 70%.
When we talk about the recommendations, again, that there are no proven recommendations that the live birth rate of the couple is increased after giving all these things. More so when you're giving steroids and along with that you combine the low molecular weight heparin, you have to be more careful about osteoporosis in the patients. And if you have to start, then maybe only trimester people do start thrombocytopenia as well. So recommendations say no. There is no role of starting IVI.
No role of steroids.
Okay.
Yes, no.
You tell me one thing, Amrita. How this labor and delivery will be managed in women on anticoagulation with heparin?
Ma'am, we have to monitor the patient carefully, like maternal and fetal monitoring should be done properly. We should stop the aspirin at 32 weeks, 36 weeks or 7 to 8 days prior to delivery. And we should shift the low molecular heparin to unfractioned heparin before 6 to 12 hours before the delivery.
24 hours.
Suppose the patient goes in labor with heparin on.
Yes, ma'am. Sorry.
Then what will you do?
If the patient goes in labor with the heparin on, what will you do?
Sudden PRM or sudden whatever happens.
Yes, ma'am. Sudden. There are more chances of PPH in such a patient, ma'am.
They are not that high. And secondly, what is the antidote?
But unfractioned heparin is, ma'am. Hello.
If the patient is on unfractionated heparin, what is the antidote for heparin?
Ma'am, protamine sulfate can be given.
Okay.
Sorry to interrupt you, ma'am. We have only 5 minutes.
I think it's your patient is on prophylactic doses of aspirin and low molecular weight heparin. She is not receiving heparin for any thrombotic prior episode for which you want to maintain a anticoagulant level. So I think this can be continued. The recommendations say that it can be continued 1 day prior till the delivery. So there's no need of stopping the low dose aspirin and low molecular weight heparin. And you need not even shift her to unfractionated heparin for a day.
No, if she on, that is what was said.
If she answered that way that we will start her on unfractionated heparin.
No, there is no.
We may not start her on unfractionated.
Yes, ma'am. The book says we have to do that, but there is no such a rule. Like with low molecular.
You have to do it when she is on. Amrita, you have to do it when she is on, a therapeutic heparin doses. She's for prophylaxis.
Epidural hematoma and all these things.
Yes, ma'am. Yes, ma'am.
What is the difference between therapeutic and prophylactic? When do we give anticoagulant therapy?
Ma'am, if there are previous episodes of RPL with previous episodes of thromboembolism, then we give therapeutic dosing.
Yes, in those cases, you may even need to start warfarin in between, right? To maintain the dose.
Yes.
This is not that. Fine. Okay.
Amrita, what is your take on laparoscopic encirclage in patients with cervical insufficiency?
Laparoscopic, ma'am, what?
Encirclage.
Yes, ma'am. Ma'am,
Which are where you would like to do a laparoscopic encirclage in patients with cervical insufficiency as a cause for RPL?
Ma'am, if the vaginal encirclage is felt
Yes.
then we can do laparoscopic encerclage.
When would you like to do that? During pregnancy or pre-pregnancy status?
Ma'am, we can do pre-pregnant if that is proven there is the cervical insufficiency after pregnancy, ma'am. Because if if there is anomaly or anything after
Very good.
anti-scan and double marker, we only do cerclage.
Yeah,
What
but there
do you
are
mean by rescue
times it
cerclage?
can be done even pre-pregnancy status also. Okay.
Amrita,
Yes,
can you
yes,
tell
ma'am.
me only one last question? What do you mean by rescue cerclage? And when should you do this rescue
Yes, ma'am.
cerclage? In which period?
It is done for the patient in which the cervical dilatation already occurred. There is bulging of the membrane. Then we do rescue cerclage.
How do you
What
do
type
it?
of cerclage? What is the name of that?
That's
Worm cerclage, Hefner's
Very
operation.
good.
How do you
Wombs.
do it? Just tell me. Have you ever
There are two
done?
sutures taken, ma'am. At
Just
from
push the membrane.
uh,
You have to push the membrane up, then only
yes,
you can do the.
upwards, ma'am. We have to push the membrane, and there we took two reverse
How
sutures.
you say? By what?
A horizontal mattress and a vertical mattress.
Cell mattress. Yes.
Okay. And before that, as madam is saying, you have to push the membranes inside.
Membranes
And what are the ways of preventing a rupture of membranes, you tell us? How will you prevent that? If the membranes are bulging and you want to give a rescue? Any position?
By lithotomy position.
Are?
Sorry, ma'am.
Head low position.
Head low position in lithotomy. Head low lithotomy.
And what else would you like to do? You can even put a sponge holder with a gauze in it and push it inside. And as you are tying it, you can take it out. Or a Foley's catheter with a balloon inflated can be put inside. And then you deflate the balloon and take it out.
That is the best part. That is the way you should be ideally doing with the police cat. Okay. Yeah.
If you are taking the patient for elective cerclage at 16 weeks, you said that one thing you would like to do is anomaly scan. Another important test that you will like to do before posting the patient for cerclage.
Ma'am, double marker before doing cerclage. Or
The
if the
anomaly
she is
part.
16 weeks, then
Leaving
she
the
is.
anomaly part, do you want to see something else? Leaving the anomaly part, do you want to see something else which can lead to preterm labor? Yes, we are concluding.
Can we please conclude the case, ma'am?
Yes, yes, we are just.
Yeah, I wanted to say you should rule out cervical infections. Okay, send a high vaginal swab right at 14 weeks.
Swab, yes, ma'am. And by yes,
and
antibiotic should be
done
really good.
And it should be taken the high vaginal swab and everything in such patients of RPM.
Amrita, you have done really good. The case was quite interesting and you answered almost all, and all the best for your exams.
Thank you so much.
Nicely done, Amrita. Congratulations.
Thank you so much, ma'am.
All the best, Amrita.
Over to Sanyukta.
Yes, ma'am. Thank you, Amrita. Very well presented. Thank you, Dr. Shama Kedar, ma'am, Dr. Anuja Bhalerao, ma'am, and Dr. Prachi Dikshit, ma'am, for giving us your precious time and for sharing your knowledge and guidance. Thank you so much, ma'am. We are moving to our next case on fibroid in young patient. Our presenter is Dr. Shobna Singh from GMC Nagpur, and our faculty judges are Dr. Aruna Kekre, ma'am, Dr. Nima Acharya, ma'am, and Dr. Shama Kedar, ma'am.
Dr. Aruna Kekre, ma'am. She is a former professor and HOD in Department of OBGY and head of Urogynecology Unit, CMC Vellore. She has n number of publications, more than 50 in index journals. She has teaching experience of more than 37 years. She has been postgraduate teacher for DGOMD National Board for Lady for more than 35 years. Her areas of interest are urogynecology, pelvic floor reconstructive surgeries, urinary incontinence, and menopause. We welcome you, ma'am. Our next faculty is Dr. Nima Acharya, ma'am. She is professor and head of the department in Datta Meghe Institute of Medical Sciences, Wardha. She has been UG and PG teacher since more than 15 years. She has been trained in basic and advanced course of infertility management and gynecologic endoscopy. She has vast experience of basic and advanced training in research methodology. Her achievements are, she has been a receiver of award Korean Young Researcher Award at National Conference AICOG Mumbai 2013. She has also received Wonder Foxian Award 2019. We welcome you, ma'am. Our next faculty is Dr. Kshama Kedar, ma'am. She's also with us. Start your
screen and unmute yourself. Shobna, start presenting your case.
Yeah, go ahead.
Shobna, start presenting your case.
Am I audible, ma'am?
Yes, yes.
Yes, Shobna, you are audible. Please continue.
Good afternoon, ma'am. Today I am presenting a case of abnormal uterine bleeding in a young patient with leiomyoma. This is a case of a 34-year patient, resident of Nagpur, married since 2 years, nulli gravida, nurse by profession, anxious to conceive. She was admitted in Department of OBGYN GMCH Nagpur with chief complaints of severe pain during menses since 1.5 years. There was history of passage of heavy clots in 6 months. The screen is locked.
Your slide share, yes.
There was a history of dull aching pain in the lower abdomen since 6 months. There was history of weakness and fatigue since 3 months. There was no history of irregular vaginal bleeding in between the menstrual cycles. There was no history of nausea, vomiting. No history of bowel or bladder disturbances. There was no history of decreased appetite or weight loss. Her menstrual history, she attained her menarche at 14 years. Her last menstrual period was 15th of December 2021. And her cycles were regular with bleeding for 3 days and a 24 to 25 day cycle, which were associated with dysmenorrhea. Her menstrual pain usually starts 1 to 2 days prior to menses, and then it was relieved 1 to 2 days after menstrual flow. And she had to take occasionally analgesic for the same. It was associated with passage of clots with soakage of 3 to 4 pads. She said in the pads, it was there were clots only. There was no very active bleeding. Her obstetric history, she was married since 2 years with primary infertility. On occupational history, she is a nursing staff at GMCH Nagpur since 12 years with duties in the night, changing shifts. Her socioeconomic history, she belongs to middle socioeconomic status. Personal history was not significant. In February 2021, she underwent hysterolaparoscopy in a private hospital during her evaluation for heavy menstrual bleeding and infertility. And the findings that time were, there was hysteroscopic removal of 2 fibroidal polyps. The size was not mentioned. And there was evidence of 3 by 4 centimeter fundo posterior and 2 by 2 centimeter posterior intramural fibroid. The cavity was found on hysteroscopy. It was distorted with both ostia were visualized well. Past medical history in February 2021, she was diagnosed as a case of hypothyroidism and she was started on tablet Thyrox 15.5 microgram daily. There was no history of asthma, hypertension, diabetes mellitus or tuberculosis. In family, the family, she has 2 siblings, 1 brother and 1 sister. There was no history of obesity in her family. She consumes mixed diet. On contraceptive history, there was no history of any IUCD use or oral contraceptive or barrier contraceptive device usage. Drug history, there was history of analgesics, as I said, for the dysmenorrhea occasionally. There was no history of any other drug intake. Patient gave regular history of regular coitus 3 times a week with and there was no history of any dyspareunia. Husband personal history. Her husband is 38 years old, average build, software engineer by occupation with morning shift duties. There was no significant medical history. There was no history of smoking, alcohol or tobacco in her husband. On physical examination, her BMI was calculated to be 30.1.
Shobna, can I interrupt now?
Yes, ma'am.
You started the history saying that this lady presents with a leiomyoma or fibroid uterus. That's not the way you start.
Yes, ma'am. No, ma'am.
You introduced initially saying that I'm presenting a lady with fibroid uterus. So
Yes,
you just start with the clinical history. You don't have to give the diagnosis to start with. This patient has got primary infertility and probably fibroid, but then that comes in history. You should not start with that. Second thing was, you mentioned her menstrual cycle, no intermenstrual bleeding. When you mentioned that there's no irregularity in the menstrual cycle, that means the periods are normal. Because in a patient who has got abnormal uterine bleeding, it is not just the intermenstrual bleeding which is important. There are different abnormalities in the bleeding that can occur. So these are the two important things I think in your clinical history you should keep in mind.
Yes, ma'am.
Okay,
Yes,
go ahead.
Yes. On physical examination, her BMI was 30.18. Her weight in 2013 was 57 kg, and this year her weight was 60. That means she gained almost 10 kg weight in last 9 years. There was mild pallor present. She was afebrile. There was no edema, cyanosis, jaundice, bleeding from any other side. There was no evidence of petechiae or ecchymosis. UPT was done. It was negative. No evidence of any acanthosis, nigrans, or excessive facial or body hairs. Her blood pressure was normal. Pulse was 92 regular and normal respiration.
Okay, what does acanthosis mean? What is acanthosis?
Ma'am, it is actually a cutaneous marker of insulin resistance, which is which is mostly seen on at the nape of the neck. It is a velvety like patch, which is basically seen in it is basically a marker of insulin resistance, which is usually seen in
hyperinsulinemia. You know what is Inherin syndrome?
Yes, ma'am. It is a syndrome of PCOS, which is hyperandrogenism, insulin resistance.
Okay.
Yes, ma'am.
Good. Go ahead, Shobna.
With on systemic examination, her breasts were normal. The nipple areolar complex was normal. There was no evidence of any nipple discharge. Thyroid examination was within normal limit. She was conscious with good cognition. Cardiovascular examination was within normal limit. Respiratory system was also normal. On gynecological examination, first we did abdominal examination. On inspection, there was evidence of scar marks of previous laparoscopic surgery at the port sites. Umbilicus was centrally placed. On palpation, obesity was present. There was no organomegaly. On percussion, no significant abnormality was there. No ascites. Auscultation, no significant abnormality. Bowel sounds were normal. On the genital examination, external genitalia was normal. On per speculum, the cervix vagina was healthy. There was no evidence of any discharge. On per vaginal examination, when we did bimanual examination, uterus was 8 to 10 week size, anteverted, irregular, cervix mid-placed, tubular, bilateral fornices was free, non-tender. There was evidence of a mass of 5 by 5 centimeter, which was palpated at fundus of the uterus, which was firm in consistency, regular margins. It was non-tender. Its mass was not separated. It was not felt separated from the uterus, and it was moving with the mobility of cervix. On per rectum examination, there was no mass or nodularity.
Okay, 1 minute, Shobna.
Yes, ma'am.
Go back. You mentioned that there is a mass in the fundus of the uterus. It is very difficult to say whether that, because patient is so obese. You have mentioned the patient is extremely obese with a big BMI, abdomen is very flabby. So it may be very difficult to say exactly that the mass is at the fundus of the uterus. But anyway, having said that there's a mass in the fundus of the uterus, you have to move the mass to see if there is transmitted mobility to the cervix.
Yes,
okay, you should not move the cervix to see if the mass is moving. It should be other way around. You need to move the mass to feel the mobility to the cervix. All right? Okay.
Yes,
so transmitted, that is called transmitted mobility.
Transmitted mobility to the cervix of the mass.
Yes.
Shobna, can you go back?
Yes.
Shobna, can you go back to the same slide, PV findings?
On PV findings, ma'am.
Yeah. See, madam has already told you, but what I feel is once you are already declaring that it is felt at the fundus, then again you are saying that mass is not separated from the uterus. It doesn't make any sense, right? So when you describe it properly, right? Before you are saying that it is, definitely you could localize it in the fundus. And then there is no point in saying that it is not felt separate from the uterus, isn't it?
Yes, ma'am.
Right. So when you describe
Any other thing, Shobna, apart from what you have mentioned on pervaginal examination, you need to also look at associated endometriosis in a patient with fibroid, because she's already been investigated and treated. So how do you know that this patient has got associated endometriosis? One is by history and the second is by clinical examination. History, the patient will have dyspareunia, patient will have dysmenorrhea, congestive type of dysmenorrhea, and the patient will have dyschezia. So triple D's is suggestive clinical evidence of endometriosis. And then when you do a vaginal examination, you also need to mention if there is any nodularity in the
Nodularity, yes, ma'am.
and if the mass is tender, if it is in the adnexa, and if the cervical excitation is positive or negative. If cervical excitation is positive, if there is tenderness on vaginal examination, and there is nodularity in the pouch of Douglas with a fibroid, you know that this patient has not only got fibroid uterus, but she's got fibroid with associated endometriosis. So in primary infertility, it is also important to make sure that your clinical examination rules out endometriosis. Your investigation will you can figure out easily, but clinical examination, I think, is very, very important.
Yes, ma'am.
Okay. Go ahead, Shobna.
Yes, ma'am. So my provisional diagnosis is 34 years nulli gravida with abnormal uterine bleeding, leiomyoma, under evaluation.
Okay, Shobna, you tell me one. Okay, go ahead. Go ahead.
Ma'am, investigations were done. CBC was normal. Hemoglobin was 12 gram%, WBC normal. Then the liver function test, kidney function test, electrolytes, they were all normal. Vitamin B12, lipid profile was also normal. Coagulation profile was normal. And the basic routine, triple H, HIV, HBsAg, cycling, everything was normal. Then during her evaluation in 2020, her AMH was found to be 0.29 nanogram per ml. Serum prolactin, testosterone, and HbA1c, these investigations she already did, and they were within normal limit. Then in her thyroid TSH in February 2021, it was 5.4. At this, she was started on Thyrox 12.5 microgram OD daily. And in December, when we operated her in December 2021, her thyroid pre-operatively was normal, 3.8. Her husband's semen analysis was done in August 2020, which was the total sperm count was less, motility was 45%, and at this report, her husband was started on her medicines for 3 years, cynomycin and multivitamins, and they repeated her semen analysis after 4 months, which was within normal limit. Her imaging, gathering all her imaging what she has done in the last 2 years on transvaginal sonography in September 2020, ET was 9 mm. Uterus was 8.4 by 5 centimeter. Left ovary and right ovary were almost normal. Fundal fibroid, there was evidence of fundal fibroid of 2.8 by 3 centimeter and posterior fundal fibroid 1.5 by 2.5 centimeter. On hysterosalpingography, which was done in September 2021, the cavity was found distorted. There was left-sided free spill, but the right-sided there was evidence of delayed spill. During her polypectomy, when she underwent hysterolaparoscopy in February 2021, the endometrial curettage was done, which was suggestive of benign endometrial polyp with glands in proliferative phase. Her ultrasound was done in November 2021, which was suggestive of uterus bulky, 10.7 by 6.4 by 7.8 centimeter with 89 millimeter with multiple hypoechoic lesions in the posterior myometrium of approximately 5. There was one 5 by 5 centimeter at fundus, 3.4 by 3.9 centimeter at anterior wall, 3 by 2 centimeter at posterior wall, and there was one seedling which was over the anterior wall of the uterus. And there was evidence of simple serous cyst of approximately 2 by 1.8 centimeter. Chest X-ray and 2D echo were normal. Her course of the disease in the last 2 years. She got married in January 2020. Then after 6 months, she is well educated. She is a nursing staff, and considering her age, 34 years, she herself went to a gynecologist at a government hospital. When her AMH came out to be 0.2, the follicular studies was done, and she received 1 cycle of clomiphene citrate. Considering her AMH, IUI was planned, but her husband's semen analysis was abnormal, so husband was given treatment. Then from February 2021, she went to a private hospital where histolaparoscopy was done with removal of 2 fibroidal polyps of small size. Again, she received clomiphene and letrozole 2 cycles. Again, IUI was planned, but the cavity was found distorted. And during this phase, she was tested COVID positive. So she didn't follow up. Then in December 2021, she came to us when we decided to take her for laparoscopic myomectomy. The patient is still at follow-up. The plan of management we did is laparoscopic myomectomy for this patient.
Shobna, 1 minute. You planned for a myomectomy. What was the indication of doing a myomectomy?
Actually, ma'am, the myomectomy we didn't do. We have not done just for infertility purpose, but basically it was done for a dysmenorrhea and menorrhagia. Yes,
correct. Yes, I agree. Totally agree that with all these things, the chances of fertility are quite poor in her situation. But whatever treatment you are going to plan on her is because she's symptomatic with heavy menstrual blood loss, and also she's got severe pain during menstrual cycle. But if fertility was not an issue, would you have treated with medical treatment?
Yes, ma'am. If fertility
was not an issue, imagine she's not fertile. Fertility is not an issue.
Yes, ma'am.
In this situation, would you have given a medical treatment?
Yes, ma'am. Yes, ma'am. Ma'am, the management of fibroids actually depends on 4 factors. Like one is age, second.
No. Just answer my question. Don't give me the theory part of it. Just answer my question.
Yes, ma'am. Yes, ma'am. We would have tried the first year treatment like oral contraceptive pills or Mirena. Or if she don't want any hormone.
No, Shobna, 1 minute. I don't think Mirena comes into picture right now. Her main symptoms is heavy menstrual blood loss. So the treatment would have been to give her oral contraceptive pills, okay, but you could have given a tranexamic acid that will reduce the pain.
First tranexamic acid one should be giving.
1.3 gram TDS it can be given. Tranexamic acid can also be given, and her symptom, because of the bulk symptom, we would have tried uterine artery embolization also.
No, wait, Shobna, you are going very fast.
You are running very fast.
You are running. What we wanted to know is what is the medical management in a not in your case, in general, if it is not an infertility, just a 38 years old lady, what would you have done? First is tranexamic acid, yes.
May I interrupt? Yeah, very good afternoon, Kedar ma'am and Kinkri ma'am. May I interrupt? Shobna, I think you know what you have presented the case as a diagnosed case of fibroid. If you take her as 34-year-old patient who has entered your OPD with menorrhagia and dysmenorrhea, and she has a 8 to 10 week size, firm, regularly enlarged uterus. Just take it like that, isn't it? So could you clinically give us some differential diagnosis first?
Yes, ma'am.
Because you presented with the whole investigations which you already have with you, right? In your exams, I think we all are discussing from exam point of view. You are not going to get any,
what I said. She started with
because you're not going to get any investigation reports better. You're not going to get any file to see, right, on the exam day. So she has a regularly enlarged uterus, which is 8 to 10 week size now. She's 34-year-old, obese, maybe anxious to conceive also, what you presented like that. Now, how do you approach to diagnose? First, your provisional diagnosis 1, 2, 3, and then your approach to diagnosis by investigations, and later on how you manage, right? So first give me provisional diagnosis 1, 2, 3 with this kind of clinical finding. Just forget that you know that she has a fibroid.
My differentials, there could be endometriosis, 1. Second, adenomyosis.
Okay.
Endometriosis will not produce this type of symptoms, right?
Yes, ma'am. Endometriosis.
In endometriosis, patients usually present with pain, but not with heavy menstrual blood loss. The first important, you just imagine, the palm coin classification of abnormal uterine bleeding. So it could be, as you rightly said, it could be a fibroid and adenomyosis. These are the 2 important things that you should keep in mind, right?
Yes, ma'am.
Okay. Any other differential diagnosis?
Ma'am, with polyps can be there in view of heavy menstrual bleeding.
Okay. Anything related to reproductive age group with this kind of heavy bleeding? Maybe the first episode of bleeding.
Yes, ma'am.
Anything related to reproductive age group? Just forget, what investigations you have got, just forget it. She has come to you with first episode acute bleeding like that. She's 34-year-old, right?
Yes,
married, anxious to conceive, 8 to 10 week size, little firm uterus, enlarged. What else would you like to rule out? You have already mentioned in your investigations. Hello, Shobna.
Yes, ma'am.
Would you like to rule out pregnancy also or pregnancy related bleeding?
Yes, ma'am. Sorry, ma'am.
Yeah.
Yes, ma'am.
Isn't it? So because she's in the reproductive age group. Okay.
Yes, ma'am.
Right. So how do you proceed with
How
investigation?
would you clinically differentiate between adenomyosis and a uterine fibroid?
Ma'am, first is on the ma'am, on clinical. On examination, we can differentiate. Usually, uterus enlargement of uterus in fibroid is irregularly enlarged, which is non-tender, which is mobile. Then, but in adenomyosis, there is dysmenorrhea. Then it is tenderness will be there.
Okay. Is with the fibroid, is the uterus always mobile? What are the situations in a fibroid where the uterus is not mobile at all? When the patient has got pelvic inflammatory disease.
When it is associated with any pelvic inflammatory associated with PID, then there will be fixity in the bilateral fornices. We can't see as free.
Okay. Any other situation where you cannot move the uterus? Endometriosis. So these are the two situations where uterus is not mobile, freely mobile, or it can be even a retroverted fixed uterus in patients with endometriosis and pelvic inflammatory disease. Okay. So the regularity and irregularity of the uterus are the two important things which need to be mentioned on your clinical examination, which you have already done. Okay.
Yes, ma'am.
Now, in a normal situation, would you have done an endometrial sampling in this patient? She's 34 years old. Forget about infertility. But if she had heavy menstrual blood loss with clots, would you have considered with this 4 centimeter, 5 centimeter fibroid?
Yes,
would you have
ma'am.
considered doing the?
Yes, ma'am. Yes, ma'am. Because of our obesity, there might be chances of unopposed estrogen excess. So the conditions like the patient on tamoxifen use or obese, which is hypertensive, then endometrial sampling is an indication in such patient as per ACOG 2016.
Okay, so you would consider, what are the other risk factors for considering a DNC in a patient with heavy menstrual blood loss?
Then, ma'am, when we are suspecting any endometrial hyperplasia,
okay.
Then, in case of ma'am polyp also, because there is
polyp, you will not do a DNC, you will do hysteroscopic
polypectomy along. Yes, ma'am.
Okay. So the very, very definite indication of doing a endometrial sampling is in a patient who's obese, hypertensive, diabetic with a family history of endometrial malignancy, or in a patient who's got chronic anovulation. These are the situations where the patient is likely to develop endometrial hyperplasia, and you would like to rule it out before you start medical treatment. But run-of-the-mill patient who does not have any of these high-risk factors, it may not be really indicated. Okay, so endometrial biopsy just came as proliferative phase endometrium.
Yes, ma'am.
What else would you do?
Yes, ma'am.
Yes. Clinically, whatever differential diagnosis which you have given, right? How are you going to confirm it? Or how are you going to at least come to a narrowed down diagnosis? What do you do exactly when such a patient comes to you? A specific any investigation which you routinely do, I think.
Ultrasound.
Yeah. So what all findings?
What UPT?
Yeah. What will you see if there is hyperplasia? What will you see if there is fibroid? What will you see if there is adenomyosis? Any specific features?
On ultrasound, ma'am?
Yeah.
Yes, ma'am. Ma'am, on ultrasound, in case of adenomyosis, there will be loss of the endomyometrial junctional zone, and And in case of fibroid, there will be hypoechoic lesions will be seen in the myometrium. Then other other investigation can also be done, like transvaginal sonography.
Okay, that only you are doing, no, presently. Then what will you see in hyperplasia, polyp?
Ma'am, in polyp, ma'am, ideally polyp cannot be differentiated from fibroids.
Okay.
So we have to do TVS along with the Doppler.
Okay.
Because polyp will have a single feeding vessel and fibroids will have multiple feeding vessels. Then ma'am, if we are suspecting endometrial hyperplasia, then the NC should be done, ma'am.
Okay, let me ask you, Shobna, supposing the transvaginal ultrasound shows a 3 to 4 centimeter polyp. Okay, do you know how do you classify the polyps? What is the classification of an endometrial polyp?
Ma'am, polyps, endometrial polyps.
Yeah, how do you classify endometrial polyps?
Ma'am, there are 4 types, ma'am. One is mucosal, second is endometrial, third is placental polyp.
No, Shobna. There is a Mesticker classification of an endometrial polyp. Type 0, type 1, type 2.
Yes, ma'am. Ma'am, there is a step W classification, which is
that is different.
No, ma'am. No, that is for hysteroscopic removal. Sorry, ma'am.
Yeah.
Ma'am, yes, ma'am. There is type 0, type 1, type 2, and the 0 is which is pedunculated in the uterine cavity itself. Then 1 is which is less than 50% into, which is more than 50% towards the cavity. Then 2 is which is less than 50% into the cavity.
Okay, and what is 3?
Ma'am,
and what is the clinical significance of type 3 fibroid? As a clinician, I think it is extremely important to know what is the importance of knowing a type 3. Type 3 is when it is plump in the myometrium, but it is distorting the uterine cavity.
Ma'am, fibroid or polyp, ma'am?
Polyp.
Polyp, yes, ma'am.
Yeah.
Which is, yes, ma'am, which is
type 3. Type 3 fibroid.
Yes, ma'am. It is basically, its management becomes difficult because it is more towards the myometrium or myometrial cavity.
It is touching the endometrium, and that is why it distorts the uterine cavity. And whenever the uterine cavity is distorted, there is a chance that the patient will have severe abdominal pain during menstrual cycle. If you try to put in an intrauterine device in a patient with a distorted uterine cavity, either it may not go or there is an increased chance of expulsion. So that is one thing which we need to keep in mind when you're dealing with a distorted uterine cavity. As far as possible, avoid using an intrauterine contraceptive device for a LNG IUS. Now, what is the stepwise classification?
Yes, ma'am. Ma'am, step
W classification.
This classification is basically for hysteroscopic removal of the polyps. Of the fibroids, ma'am. Fibroids. There is a score system. It consists of size, topography, extension of the base, step, then P is penetration, and W is the extension to the lateral wall. And it says if it is 0 to 4, then hysteroscopically these can be removed. If it is 5 to 6, then it is very difficult to remove hysteroscopically, or 2-stage hysteroscopic removal can be done. But those who are more than 7, ideally we should not they are not preferred for hysteroscopic removal.
Okay, fine. Okay, very good. I think you have answered it very well. Now we go to the management. Now, so you need to do a proper clinical examination and investigations before you plan on management. So you have planned on laparoscopic myomectomy. Okay. Yes, and what the indication is for the symptoms and not for fertility.
Not for the infertility. Yes, ma'am.
Yeah. Okay. Yes, so how would you choose a patient for myomectomy?
Yes, ma'am. Ma'am, myomectomy, ma'am, it is the patient who is young, infertile, who wants to preserve the uterus. Then and ma'am, when medical management has failed.
Okay. Is size of the uterus taken into consideration before you do a myomectomy? Is the number of fibroids taken into consideration before you do a myomectomy? Or we go back to prior to doing a myomectomy, laparoscopy or open, what is the counseling that you need to do for a patient?
Yes, ma'am.
How would you counsel a patient for myomectomy, be it laparoscopic or be it open myomectomy? How would you counsel a patient?
Ma'am, first counseling should be done that there are 50% chances of the recurrence of the myomectomy.
For all patients with myoma, is there a 50% chance of recurrence? How do you decide that this patient is going to have a recurrence? This patient, I'm pretty sure she will not have a recurrence.
Ma'am, it basically depends on the site of the myoma. On site
No, it doesn't depend on the site. It depends on the number of myomas.
If they are less than 5 myomas, less than 5 in centimeter.
Okay.
Yes, ma'am. And the
A
uterus.
single myoma, it's not the size, it is not the situation. If a patient has got a single fibroid, the chances of recurrence are less. But if a patient has got multiple fibroids, there is a chance of recurrence about 11 to 12% in the next 5 years. So if this patient has got multiple fibroids, the whole uterus is studded with a myoma. So this patient may have a chance of recurrence. Okay. So that is one thing that you need to explain to the patient. Okay, very, very important, because the first thing the patient asks you is what is the chance of recurrence. So it depends not on the size, not on the site, but it depends on the number of fibroids. Despite of having a single fibroid, there is always a chance of recurrence, but slightly less than in a patient who has got multiple fibroids. Okay. Other counseling, pre-op counseling? Any other thing you would like to decide to counsel the patient prior to myomectomy?
Okay, can you tell me after, yes, ma'am, after ma'am's question, you just tell me one more thing. What is the probability of complications in such patients of laparoscopic myomectomy?
Ma'am, there can be hemorrhage.
Answer ma'am's question. Yeah.
Hello.
So you have to counsel regarding bleeding, intraoperative bleeding.
Ma'am, regarding intraop bleeding, then there may be a risk of hysterectomy. It can land up into laparotomy also. We should also counsel them. Hysterectomy consent should be taken. Then, ma'am, with proper arrangement of the blood and blood products, then the other causes of miscarriage or infertility should be ruled out.
That you already, we are not doing it for infertility, Shobna. You leave aside that. You're doing a laparoscopic myomectomy or an open myomectomy. One is chances of recurrence, second is hemorrhage, third is opening the uterine cavity. These are the three important things. And fourth is the possibility that she can get pregnant or not is not definite. So these are the four things that you need to counsel a patient prior to doing a myomectomy, and the need of hysterectomy if need be, if the bleeding is torrential and you're not able to control, which should be the last one, because otherwise you are telling the patient. So if you feel during a laparoscopic myomectomy or an open myomectomy that the bleeding is torrential, then probably it may be safer to stop doing it rather than taking the uterus out in a patient who is 34 years old. All right. So now coming to Dr. Shama's question, what are the complications of myomectomy?
Sorry to interrupt you, ma'am. We are left with only 5 minutes.
Okay.
So
fine.
Yeah. Can we please conclude the case?
Okay. So laparoscopic myomectomy you have done. And if the patient becomes pregnant, you need to know what are the consequences of opening the uterine cavity. When would you like to do a cesarean section? When would you like to do an open, when would you like to do a normal vaginal delivery? So implications of fibroid in pregnancy and and during pregnancy is again one thing which you have to be very careful about. And you need to know what are the implications of removing a fibroid and keeping a fibroid. Some small fibroids may be remaining there. The fibroids can increase in size and there could be associated problems. So I think it is important to know that. And because of short of time, I think we will conclude. Shobna, your presentation was very good. I think you concluded, your clinical examination was good, your history taking was good. And I think you have done a fairly good job. Congratulations.
And can I have just 1 minute, ma'am, please?
Yeah, please go ahead.
Yeah, thank you, Dr. Shobna. It was a very nice case presentation.
Just one minute, ma'am, please, ma'am.
Yes, please.
Ma'am, I just want to conclude one thing, ma'am. Ma'am, in the post-operative period, we gave her progesterone therapy for approximately 2 to 3 months, and she had her last menses on 14th of February. It's about her follow-up, and it was bleeding for 3 days with average flow, and it was not at all associated with dysmenorrhea like before. And the sister, she was very happy, and we have counseled her regarding the need for IUI and IVF. And intraoperatively, ma'am, there was actually opening of endometrial cavity, which was confirmed with the methylene blue dye, and she is the sister with due cousin, ma'am.
But that was the question of Dr. Kekere. What?
Yes,
How will you follow up when the cavity is opened?
Yes, ma'am. Yes, ma'am. Actually, ma'am, cavity was opened, which was diagnosed with
So
the
after she becomes pregnant later on, what will you do? Just last question.
Ma'am, elective cesarean section should be done in these patients.
At what
with proper
gestation?
counseling. At 34 weeks, ideally, we admit them electively, ma'am. 34 to 37 weeks.
34 is a bit too early. 34 is a bit too early. You can hold on. When you're admitting the
37.
patient. Yeah.
ma'am.
Again, she's under your care, under your surveillance. So you need to wait till the baby matures at least to 37, unless she goes into labor or unless she has got some pain.
You can go after 36 also, but you can keep her for 37, and as soon as she completed 37, you can go ahead with the elective section.
Yes, ma'am. Yes, ma'am.
What other complication do you anticipate if the placenta was also fundal?
Ma'am, there is abnormal presentation seen in there will be placenta, creta, or no, ma'am, no, ma'am. Abnormal presentation there can be preterm labor, there can be postpartum hemorrhage, or all these can be side effect of because it is a full length hysterotomy scar. It is like a hysterotomy scar, which is very dangerous. And rupture of the uterus should always be kept in mind, ma'am.
Yeah, good job, Shobna.
Thank
you, Shobna. You present for your exam point of view, no? Never
Yes, ma'am.
give all the investigations and what you did. All that need not be mentioned on your. You can keep it for yourself, but you need not project it. You know, at the end of presentation, you will be presenting till the clinical diagnosis, right?
Yes, ma'am.
And then you have to give differential diagnosis.
Yes,
And
ma'am.
according to the last picture, she doesn't seem to be BMI of 30. Maybe you've done a good lifestyle management. Doesn't seem to be a BMI of 30.
She has lost, ma'am.
I also agree with Dr. Nima that you should not be telling us the investigation. So in exam, it will be not be given to you. And you should be starting with the DDs and everything. You should not jump on the conclusion because it was a AUBL case. It doesn't mean that you should be jumping on that case.
Don't start with the diagnosis. Yeah. You come to a diagnosis, narrow your diagnosis and come to a diagnosis of whatever it is.
Sure. All the best, Shobna. Yeah.
Yes, ma'am.
Thank you very much.
Kedar ma'am.
Thank you, Nima. So
Thank you,
nice
Dr.
to see you.
Shobna.
Prachi ma'am, for the opportunity. Thank you, organizers.
Thank you, ma'am.
Thank you, organizers.
Thank you, all the judges. Thank you, Dr. Kshama Kedar ma'am. Thank you, Nima Acharya ma'am. And thank you, Aruna Kekre ma'am, for your valuable time in judging the session. This was the last case presentation of the day. Now we move towards our next session on skill station videos. The first skill station video is on postpartum intrauterine device insertion.
वहां से ऑडियो देखिए ना
नहीं
नहीं है ना?
if the correct procedure is followed carefully. This procedure can be done immediately after the placenta has been delivered, and it is described as the post-placental IUD insertion or simply as PPIUCD insertion. The advantage of IUD insertion at this time is that it is an occasion when the healthcare professional is already attending the woman, and since the IUD insertion takes only a minute or two, it is convenient opportunity and saves time for both of them, whilst also avoiding the need to arrange a second later visit to the clinic. Remember that active management of third stage of labor should be carried out as a normal before insertion. PPIUCD insertion can also be undertaken up to 48 hours after delivery. However, after 48 hours has passed, postpartum IUD insertion should be avoided for 4 weeks or longer postpartum. You should check that the woman has been counseled and given consent for PPIUCD insertion. You should ensure that pre-insertion checklist has been valid and there are no contraindications to it. Pre-insertion checklist contraindications are any rupture of membrane lasting for more than 18 hours, any signs of chorioamnitis, any signs ongoing PPH. Set out the sterile instrument required for the PPIUCD insertion. Long placental forceps and sponge holding forceps, often called as sponge holders. Also Sims speculum. Sometimes ring forceps are used instead of sponge holders. You should also have the IUD and a good light source available. Procedure: wash your hands with the clean water. Inspect the perineum, labia, and vaginal walls for laceration. If these are not bleeding heavily, repair them after IUD insertion. Gently insert the Sims speculum into the posterior vagina and depress in order to visualize the cervix. Clean the cervix and vagina with the antiseptic. Gently grasp the anterior cervix with the sponge holders, close to the first tooth only, and let go of the handles. Open the bottom of the IUD packet and firstly remove the long plastic applicator and inserter from the packet, leaving only the IUD inside. Then using the long placental forceps, grasp the right hand arm and stem of the IUD and remove it from the packet. Apply gentle traction on the anterior lip of the cervix using sponge holders in your left hand to lift the anterior lip up. Using the long placental forceps in your right hand, pass the IUD into lower uterine segment, taking care where possible not to touch the vaginal walls with the IUD. Keep the placental forceps closed so as not to drop the IUD into the lower part of the uterus. Once the IUD has passed through the cervix, remove the sponge holders from the anterior lip of the cervix. Move your left hand to the midline of the abdomen, filling the uterine fundus through the clean abdominal towel placed on the anterior abdominal wall. Ensure that the base of your hand is over the lower uterine segment. There is a sharp angle between the axis or direction of the vagina and the uterine cavity. The uterus needs to be elevated in the abdomen and pushed upwards to straighten out this angle. If this is not done, you may think that you feel that the IUD is against the fundus, but actually it is only against the back wall of the lower uterine segment. It is very important to place the IUD against the fundus in order to minimize the chances of expulsion, while maintaining pressure in order to elevate the uterus upwards in the abdomen. Move the long placental forceps towards the umbilicus until it reaches the uterine fundus, when you will feel a slight resistance. This resistance can also be felt by the top of your left hand, which is placed over the abdomen and positioned at the top of the uterine fundus. When the placental forceps is at the uterine fundus, its handles will be close to the patient's perineum. Remember to keep the placental forceps close so as not to drop the IUD in the mid part of the uterus. Open the long placental forceps and move them towards the right hand side wall of the uterine fundus. Slowly remove the placental forceps, keeping them open so as to avoid them catching the threads of the IUD and inadvertently pulling it out of the position. At the same time, keep stabilizing the angle of the uterus with your left hand through the abdominal wall until the placental forceps have been completely removed. Check the cervix to make sure there is no bleeding and that the IUD cannot be seen near the cervix. Remove all the instruments and place all in 0.5% chloride solution so that they are completely submerged. Dispose of waste appropriately. Remove the gloves and wash your hands. Remove all the instruments and place all in 0.5% chloride solution. Tell the woman that you have finished fitting IUD. Continue with the routine postnatal care, including immediate breastfeeding. Ensure the woman is given the post-discharge IUD insertion and record the IUD insertion in the labor ward register and in the training logbooks. Good summary. Good technique helps to reduce the chances of spontaneous expulsion. Important steps include grasping the IUD on the right hand edge while still in the sterile packet, elevating the uterus in the abdomen in order to straighten out the angle, ensuring placement of the IUD high in the uterus at the uterine fundus, keeping the Kelly's forceps open while withdrawing, checking that IUD and its strings are not seen coming through the cervix. So with this, we end the PPI-UCD skill station video. Our next video is on POPQ, pelvic organ quantification system.
അപ്പൊ പെൺകുട്ടി ഞാൻ കെട്ടാൻ പോകുന്ന കുട്ടിയാണ് ഇതുപോലത്തെ ഒരു പെണ്ണ് ആമ്പിള്ളേർ അതും കൊച്ചിയിലെ ആമ്പിള്ളേർ വെറുതെ തോന്നുന്നുണ്ടോ
Share sound. Yes.
मैडम चेक करिए ना, आवाज आ रहा है? यही है ना?
Is third degree, and when whole of the uterus is palpable outside and your fingers can go above the uterus. Pelvic organ prolapse is descent of cervix from its normal position at the level of ischial spines. When the cervix comes down, it pulls along with it the anterior vaginal wall and the posterior vaginal wall, and the upper 2/3 then is cystocele anteriorly and the lower 1/3 is urethrocele. Posteriorly, the upper 1/3 is enterocele, which is the pouch of Douglas, and the lower 2/3 is rectocele. The cervix, when descends into the vagina, it is first degree prolapse. When it comes up to the introitus, it is second degree. When it lies outside the introitus, it is third degree. And when whole of the uterus is palpable outside and your fingers can go above the uterus, it is called as procedentia. This is a subjective classification. So it was Bump and Mattison gave pelvic organ prolapse quantification classification, which is objective in nature and helps in pelvic reconstructive surgery. Here the reference point is hymen. So all points that are lying above the hymen are minus, and all the points lying below the hymen are plus. This tells us where to concentrate, on which wall to concentrate as per the grid. On the anterior vaginal wall, you have point AA and BA. On posterior vaginal wall, AP, BP. C is cervix or cuff. D is the pouch of Douglas. And you have 3 more points: the genital hiatus, perineal body, and total vaginal length. AA point maximum can be +3 to -3. AP similarly can be from +3 to -3. AA and BA comprises of the anterior compartment, AP, BP the posterior compartment, C and D the central compartment. Genital hiatus, perineal body, and total vaginal length are also measured. Genital hiatus should be around 4 to 4.5 centimeters, perineal body 3 to 3.5 centimeters, and total 10 centimeters normally in a patient who doesn't have a prolapse. Here we are showing you how to measure these. The genital hiatus is started from the mid of the urethra to the posterior hymenal ring in centimeters. The perineal body from the fourchette, posterior fourchette, to the center of the anus, that is the perineal body. This is done with the help of an IR spatula where markings have been done, and we measure it accordingly in centimeters. After hiatus and perineal body, these measurements are done when the prolapse is reduced. Now, after the genital hiatus and perineal body, we see for the total vaginal length, where we are going to put in a speculum and put your IR spatula inside till it touches the posterior fornix, the highest point, and then you are going to measure it till the hymen. This is 10 centimeters. Now, once the TVL is seen, 2 very important points need to be marked, AA and AP. AA point is on the anterior vaginal wall, 3 centimeters proximal to the urethra. So we are using methylene blue to mark this point. These points are also marked when the prolapse is reduced. So from the urethral meatus, we are marking a point 3 centimeters on the anterior vaginal wall, and similarly on the posterior vaginal wall, we are going to mark a point 3 centimeters from the hymen. So these are points AA and AP. AA is corresponding to the vesico-urethral junction. So once these points are marked, then our next step is to see to it that the patient does either Valsalva maneuver, or we are going to take out the whole of the prolapse outside. And now we need to see where these points are lying when the patient has prolapse in relation to the hymen, right? So we are able to see on the anterior wall the blue line which demarcates point AA, the vesico-urethral junction. And with the help of this marked IR spatula again, we are going to see where it is lying in relation to the hymen. How many centimeters? If it lies inside, it will be minus. Now since it is lying outside the hymen, this will be plus 1 centimeters. This is plus 1. AA is plus 1. Now this is marking of point BA, which tells you that where the cystocele touches the cervix, where the anterior vaginal wall or the cystocele touches the cervix. And the tip of the cervix is point C. We are measuring the BA point, which is around 3 centimeters from the hymen, and the cervix is lying 4 centimeters from the hymen. So BA point will be plus 3 and C point will be plus 4. Similarly, posteriorly, we had marked point AP. Now this is lying inside the hymen, 1 centimeters. So AP will be minus 1. Similarly, as we had marked it on the anterior wall, this is the posterior wall marking. This will be AP BP. So this is again plus 3 centimeters. So I repeat again. And then we are marking now the point D, because with the vaginal, with the cervical descent, the vaginal walls also come down, and so the point D will also come down, and here it was plus 4. So the TVL was, so this is again point AA, BA, this is AP, this is BP, this is point C, and this is the point D. That is the posterior fornix which has come down, which is plus 4. Now as per this classification, the stage 0 is when there is no descent, stage 1 when the descent is less than 1 centimeters, stage 2 is when the quantification value is less than minus 1 centimeter, that means it is from plus 1 to minus 1. Stage 3 is when the quantification value is less than TVL minus 2. And stage 4 when the quantification value is more than TVL minus 2. In our thing, the maximum or the most dependent part was cervix, which was lying at plus 5. So our patient has stage 3 prolapse.
So this was the video on POPQ. Moving towards with the next video, which is on Leaford's colpocrisis.
मैडम कोणता आहे
की बात करके कुछ हड्डिस में है ना उसमें थोड़ा आगे जाके थोड़ा आगे करके देखिए फॉरवर्ड
There are some technical issues. We are coming back with the video. Please stay back.
दूसरा मैडम शेयर यही है ना आगे कैसे
अपन म्यूट है जैसे हाय दीदी
संजयता, प्लीज प्राची मैम को को-होस्ट बनाओ.
Yes, ma'am.
एंड स्नेहल नाफड़े को भी को-होस्ट बना दीजिए.
1 second, ma'am. Ma'am, it's Nehal Devkar. Ma'am.
संजयता, प्राची मैम एंड स्नेहल नाफड़े को प्लीज को-होस्ट बना दीजिए.
Yeah. Prachi ma'am is co-host now.
Okay. Snehal, you trying to share your screen?
Where is Snehal? दिखो तो Snehal ना.
Snehal, are you sharing your screen?
Ma'am.
Snehal Nafade. स्नेहा को बनाया इसने.
अगं ते संजयता बनवत नाही तुला. तू दिसत नाही आहे का को-होस्ट?
संजयता, make Snehal co-host.
Ma'am, Snehal नामचं नाही है.
दिसत नाही.
With what name has Snehal joined?
सबको को-होस्ट बना सकते हैं.
With what name has Snehal joined?
स्नेहल नाफड़े.
I cannot see her.
स्नेहल तू दिसत नाही आहे.
We can't see Snehal Nafade here.
Yes. तुझं नाव काय सांग?
क्या
स्नेहाचा आहे, स्नेहल नाही आहे. 1+ आहे का? 1+ आहे का तिचं?
Marking the 2 rectangular flaps. Now we are in the anterior vaginal wall. With help Leaf-foot colpoplaces. So what are the indications for leaf-foot colpoplaces? It is usually done in cases of stage 4 uterovaginal prolapse. It can be done in stage 3 or 2 uterovaginal prolapse. Patient who is ready to compromise on sexual activity, in those patients we can go ahead with this procedure. Yes, but the patients should be completely screened for carcinoma cervix and carcinoma endometrium. It is to be done in the patients who desire minimal invasive surgeries. Patients who cannot withstand long-standing anesthesia is so in such patients it is a good procedure to be done. The basic principle behind this procedure is it is excision of the rectangular flaps from anterior and posterior vaginal walls and then suturing them together to result in partial colpoplaces. What are the complications? Urinary tract infections, bladder, ureteric and rectal injuries, hemorrhage, rarely pyometra and rectal prolapse. And yes, obviously recurrence can be a rare complication. What are the advantages of this procedure over hysterectomy? So it requires lesser time, so lesser duration of anesthesia. Fewer complications are there, speedy recovery, high success rate, and short hospital stay. So now let us move ahead towards Lefo's partial colpoplaces. After reconfirmation of our findings of prolapse, we start the procedure. We are marking the 2 rectangular flaps. Now we are in the anterior vaginal wall. With the help of methylene blue and air spatula, we are marking the flap. The flap is marked to
Sanchita, please make NKP Sims admin as a co-host.
Okay, I'm admin. Shall I start sharing?
Thank you.
Just a minute, let us tackle it with this.
So what are the indications for leaflets colpocolysis? It is usually done in cases of stage 4 uterovaginal prolapse. It can be done in stage 3 or 2 uterovaginal prolapse. Patient who is ready to compromise on sexual activity, in those patients we can go ahead with this procedure. Yes, but the patients should be completely screened for carcinoma cervix and carcinoma endometrium. It is to be done in the patients who desire minimal invasive surgeries. Patients who cannot withstand long-standing anesthesia is so in such patients, it is a good procedure to be done. The basic principle behind this procedure is it is excision of the rectangular flaps from anterior and posterior vaginal walls and then suturing them together to result in partial colpoplasis. What are the complications? Urinary tract infections, bladder, ureteric and rectal injuries, hemorrhage, rarely pyometra and rectal prolapse. And yes, obviously recurrence can be a rare complication. What are the advantages of this procedure over hysterectomy? So it requires lesser time, so lesser duration of anesthesia. Fewer complications are there, speedy recovery, high success rate, and short hospital stay. So now let us move ahead towards pre-post partial colpoplasis. After reconfirmation of our findings of prolapse, we start the procedure. We are marking the two rectangular flaps. Now we are in the anterior vaginal wall. With the help of methylene blue and air spatula, we are marking the flap. The flap is marked 2 cm from the cervix and 5 cm below the external urethral meatus. This is our anterior wall rectangular flap. Similarly, on the posterior vaginal wall, we will mark the mirror image of the anterior flap, that is 2 cm distal to the cervix and 5 cm from the anterior margin. The distal end will be there. Now, we'll infiltrate the vaginal submucosa with normal saline. Here we can use adrenaline solution as well. Adrenaline is used in a dilution of 1 in 200,000. As our patient is hypertensive, we are using normal saline for infiltration. It helps to dissect in proper planes. So anteriorly we have infiltrated, and now similarly we'll infiltrate in the posterior one. Now, the marked areas are denoted with the help of sharp dissection. The dissection is to be done in such a way so as to keep maximum fibromuscular vaginal wall. At the time of sharp dissection, if inadvertently we open the anterior or the posterior pouch, that is pouch of Douglas, we have to repair the defect with the help of interrupted sutures taken by delayed absorbable suture. As you are seeing in the video, we have removed the anterior flap, taken out the anterior flap, and now we are removing the posterior flap. Hemostasis should be achieved. It is must, as it might lead to hematoma formation later on. Now, what we are doing is the correction of cystocele, that is anterior colporrhaphy. Here we are plicating pubovesicocervical fascia with the help of interrupted sutures taken by delayed observable suture. Instead of taking a purse string suture, we are plicating it with the help of interrupted sutures. This is more important in getting a site-specific repair of cystocele. As we can see in the video, the white area, it shows a denuded part. Here there is a loss of fascia. So we will be approximating it properly with the help of interrupted sutures. We prefer to tie the suture from below upwards. It gives better approximation. So now we are done with our cyst-to-seal repair. Now let us move ahead towards the leaf-folds colpoplaces. So now we are suturing the anterior and posterior edges of our flaps. We have taken 3 sutures and we are tying it one by one for better approximation. We have placed an artery. It helps to form a tunnel and inversion of cervix. So one by one, we are tying the sutures. It is a delayed absorbable suture. The cut edges of anterior and posterior vaginal wall are sewn together with interrupted sutures in such a way so that knot is turned into the epithelium line tunnels created bilaterally. After vagina is inverted, superior and inferior margins are sutured. We can see bilaterally 2 tunnels.
Madam, unmute kar lijiye.
I apologize for that technical hindrance. After this last session of today's program, I definitely feel that it will be very helpful for all our PG students for their clinical practice as well as for their final examination. On behalf of NOGS and Department of OBGYN NKP SIMS and LMH, I would like to give my heartfelt thanks to all the participants, to our eminent faculty judges, Dr. Poonam Verma ma'am, Dr. Manju Puri ma'am, Dr. Maushmi Tadas ma'am, Dr. Bangal sir, Dr. Anuja Bhalerao ma'am, Dr. Bhakti Gurjar ma'am, Dr. Buhariwala ma'am, Dr. Kothadkar ma'am, Dr. Alka Patakar ma'am, Dr. Mugdha Jungari ma'am, Dr. Surekha Khandale ma'am, Dr. Shama Kedar ma'am, Dr. Prachi Dikshit ma'am, Dr. Aruna Kekre ma'am, and Dr. Nima Acharya ma'am. And lastly, to our students and delegate, I also thank Yash Audiovisual for technical support. We are not ending here. Tomorrow, the teaching continues with the most awaited event of NOGS PGCON 2022. That is Vidarbha level Urogyne quiz. So we call it a day. See you all tomorrow. Have a good day.
Thank you so much.